belajar besok. Nah, orangnya juga teknis juga. Biar aja nggak apa-apa. Ya kalau pas sesi diskusi kayaknya lebih baik dulu ya. Berdiri jalan-jalan aja nggak apa-apa sebenarnya. Iya sih. Derek, pas ini nggak apa-apa. Ya, mulai ya. Assalamualaikum warahmatullahi wabarakatuh. So, good morning everyone and welcome back to the summer course 2024, and today is the second day of the lecture session for this course. And I would like to say good morning also for our friends from China and another participants who join us using Zoom online. So, actually you can type in the comments or question if you need it, or if it's possible just ask to the speakers for the lecture session. And today we will have two kind of sessions. The first session, the morning session, you will study about the nutritional science and public health. Also we have the national and also overseas speakers. And for the afternoon session, you will study about the agriculture, technology, and sustainability. And for the morning session, I would like to invite the moderator for this session, Ibu Ariani Arista Putri Pertiwi, S.Kep Nurse M.N.Sc from Department of Basic and Emergency Nursing, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. For the next around 4 hours until 11:30, stage is yours, Bu Ariani.
All right, thank you very much, Mas Yopi. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. So, as mentioned, we will be together in 4 hours, so bear with me. We will discuss very interesting issues this morning about nutrition, food security in a public health point of view. As we know that our effort is to focus is also in promoting public health and also preventing diseases. So we have 4 outstanding speakers this morning. Professor Dr. Prof. Koon from Universiti Kebangsaan Malaysia, and then Ibu Mutiara Tirta Prabandari Lintang Kusuma from FK-KMK UGM, Dr. Ruhaya Binti Hasan from Universiti Sains Malaysia, welcome to Yogyakarta, and then Ibu Citra Widya Kusuma, she will join us from the US. And for the short what will happen or what will we have this session, here is the video. All right. So this session will discuss issues about school age obesity, and then also studying and until the integration health system, how we will address the issues that maybe all of you already read the discussion topic or the problem guideline yesterday within your group. We learned that there are so complicated issues that we face in our life, right? So our first speaker, is she already online? All right, cool. Professor Prof. Koon, are you there? Hi. Hello, good morning. How are you? Oh,
Very
kameranya
well,
di sini.
thank you.
Yeah, because I need to see her face, so I need to like this. Hello, Professor Bobby Koon. How are you? Can we
I'm very
hear
well.
her
Very
voice
well, thank you. Can you hear me?
louder, please?
I'm already
There you
speaking
go.
very loud. Yeah.
Can you speak louder so we can hear you
Can you
better?
hear me better now?
Yes, perfect. All right.
Okay.
So before you um, deliver your lecture, I would like to read to our audience here about you. So, Professor Bobby Koon is a professor of nutrition at Faculty of Health Sciences, Universiti Kebangsaan, Malaysia. She has more than 20 years of research experience that involves multidisciplinary and multi-country projects. Her research areas focus on childhood and adolescent nutrition, and her project covers surveys, observation, and intervention studies. Prof. Po has led many international grants, including those funded by United Kingdom Medical Research Council, United Nations International Atomic Energy Agency, International Development Research Center, International Glutamate Technical Committee, as well as those from the industry. Wow, what a huge grants. She is principal investigator of Southeast Asian Nutrition Surveys, a nationally representative survey on nutritional status of children, and Toy Box Study Malaysia, intervention aimed at reducing obesity rates through improving preschoolers' healthy eating and physical activity. It is very important issue, and we also have kind of similar issue here. Obesity during teenagers is quite challenging issue. Not only we need to treat the teenagers themselves, but also regulations, schools, activities is very influence the situation. So during this summer course, Prof. Paul B. Koon will deliver her lecture about obesity, preschool obesity management. Prof. Ko, please, time is yours.
Thank you.
All right.
Let me share my screen first. Okay. Can you see my screen now? All right, I'm
Yes.
going to assume that you can. Good
Right.
morning, everyone. Yeah, thank you. Thank you for inviting me to join this summer course and do a bit of sharing. So, what I would like to do is talk to you about the multidisciplinary approach to school-aged obesity in developing countries. This is the outline of my presentation. We will start by looking a little bit at the overview of obesity issues among children, and then we look at all the challenges, well, maybe not all, but many challenges that face school-age children in terms of preventing or promoting and curative response to obesity among them. And then we'll look a little bit at some research and the research results on how to manage obesity in school-age children before we conclude. And I will try to complete this presentation within half an hour. So first, the introduction about overview of obesity in children. So this data comes from WHO, and globally, overweight and obese children amongst the under fives numbers at about 37 million children as of 2 years ago. And half of this number are children from Asian countries. Now, on the other side, among the 5 to 19 years old, you can see that the numbers are more than 10 times more than those among under 5s. That's 390 million of overweight and obese children who are age 5 and above. And among these 390 million, more than slightly less than half of them were obese. And that's 8% of all the population aged 5 to 19 years old. So overall, from the 1990, that's like 20 years before 2022, 30 years before 2022. And over these 30 years, you can see the numbers has not just doubled, but is about 2.5 times more in terms of overweight and obesity globally. Now, how about in Southeast Asian countries? So this slide, the charts came from the NCD risk paper that is recently published in the Lancet. And what I downloaded here is a whole page of data about underweight and obesity in Malaysia. And in this chart, what they have shown is they have highlighted Malaysia, and you can see here, Malaysia, where I'm from, the prevalence of childhood obesity is about 14.6% among girls. So they put it at 15%. And that is number 2 among all Southeast Asian countries. The first one is Brunei, right? And Indonesia is not far behind. You are at number 3 among Southeast Asian countries for girls. Now, for boys, our prevalence in Malaysia is about 18%, and we are also at number 2 after Brunei. But Indonesia is, among boys, is much lower. You are at number 6. So for this competition, no point winning. It's better to be low. Right, but still we can see prevalence of overweight and obesity is quite high among Southeast Asian countries already. The next two slides, I'm going to focus a little bit more on Malaysia and the countries that are involved in CNUTs. So this slide shows you data from Malaysia only, and is about the data comes from our Malaysian National Health and Morbidity Survey, which was conducted in 2019. And in this survey, what we found that amongst the school-age children, 5 to 17 years, our prevalence of overweight is 15% and obese is another almost 15%. So in total, that's nearly 30% of overweight and obese school-going children in Malaysia. In terms of urban and rural areas, you can see the orange-colored ones, the higher ones at about 15%. Urban children has a higher prevalence of obesity and both obesity and overweight compared to rural children. Okay, on the right hand side is ethnicities, and we can see here, because in Malaysia we have various ethnicities, the main one being Malays, Chinese, and Indians. And among here, percentage of overweight and obesity among Indian children is the highest at 33%. Right. So about the CNUTS survey, that was mentioned also just now, we have conducted CNUTS twice. The first time about 15 years ago, and the second time about 5 years ago. So this data is a comprehensive data about nutrition and health, as well as lifestyle of children between age of 6 months and 12 years old in 4 countries, in Malaysia, Indonesia, Thailand, and Vietnam. And here I share with you data from these 4 countries about overweight and obesity. And this slide shows you data from CNUTS 1, which is about 15 years ago. And Malaysia at that time had quite a high prevalence, 22% in the urban and 18% in rural. And in Indonesia, much lower, 10% in urban and 5% in rural. Thailand and Vietnam is somewhere in between, except for Vietnam urban area where the prevalence of overweight and obesity was very high. It was more than 30% already 15 years ago. Now from CNUTS to data from about 5 years ago, 1 decade later, Malaysia prevalence, every country has gone up, 30% in Malaysia and Indonesia 16%. Right. So what are the causes of obesity among children? I've shared a paper with AV that she might share with you to allow you to do some extra reading when you have time, if you have time. And in this paper, it tries to tell you about what are the factors that could lead to obesity amongst children. And here you can see there are two sides to the chart. On the left side are the factors that we cannot change. So for example, genetics. We are born with the genes that we have and we cannot change our genes. So that if you happen to have genes that can make you obese, then you will grow obese. You can't change that. But genetics can interact with our environment. So in terms of interaction with environment, that might change a little bit whether you become overweight or obese. Now, on the other side is the intrauterine factors. These are the factors that occurs to us when we were in our mother's womb. And now we are adults. So we cannot go back to when we were in our mother's womb to change these intrauterine factors. So these are also considered as factors that are not modifiable. For example, was our mother obese when she was pregnant with us? What was her gestational weight gain at that time? Did she have gestational diabetes? What kind of intrauterine environment was there when we were a fetus in our mother's womb? These are factors that we cannot change. The other factor that we cannot change is our ethnicity. So for example, although I'm from Malaysia, I am ethnic Chinese, so I cannot change that, even if I can change other things about my life, right? Now, on the right-hand side, all these blue-colored things are things that we can change. For example, our socioeconomic status can influence if we are overweight or obese. We can change that. We can change our lifestyle. For example, do we have enough physical activity or not? Do we have too much sedentary time? Do we have too much screen time? We can change that. Do we have sufficient sleep? If you don't have enough sleep, you can grow obese. So remember that, make sure you have enough sleep. Now, also about diet, and there's so many things about diet. If we are babies, will we breastfeed? Um, do we take sugar-sweetened beverages all the time? Fast foods, convenience foods, breakfast consumption, and here we wrote this term called junk food. Nowadays, maybe what is more popular in use is ultra processed foods. So ultra processed foods are foods that are extremely processed, and it has a lot of additives in it. And those are known that most of those kind of foods can make us overweight and obese. Do we reduce that? What about food marketing? What about skipping meals and so on? As well as parental determinants. So for children, parents who are smoking can increase their obesity, and parents' work schedule, if the parents are very busy, lack of time to take care of their child or their child's diet and so on, that could lead to obesity. But we remember that all this we can change. There are some things that we cannot change. Right. So with these factors that influence obesity in our mind, we want to think about how we can reduce overweight and obesity amongst our children in the population. And there are a lot of challenges in that. So we will look at each of them one by one, because most children are in school. So we think that in school, if they have enough physical activity, that might lead to less overweight and obesity. However, many times in schools, perhaps not in China, I heard from my friends in China that no matter what, children have an hour of physical activity every day in school, and that is really good. In Malaysia, our physical education where the children go out to play is maybe about an hour for primary school children and less for secondary school children, and it occurs once a week. And sometimes it doesn't even occur during this period because the teacher for mathematics thinks that it's more important for the children to learn maths, for example, rather than to go outside and play. So physical education is sometimes neglected in school, which it shouldn't happen because physical activity really brings not just good health, but also allows children to have better cognition. Now, there might be in school also budget constraints for nutritious meals. And if they don't get nutritious meals, meals are less healthy, it might lead to overweight and obesity as well. What about psychological factors? Children who are obese may have very low self-esteem. They are anxious because they might be being bullied by their friends. And because of that, they are too shy to do physical activities. Or they might not be wanting to change their diet to improve their health and weight status. In terms of family and community, parents may lack knowledge or time or the resources to support healthy eating habits, for example. And in the community, maybe there is a lack of organized community at the local level or from the government that tries to establish healthy lifestyle programs for families. Now, more challenges, for example, technology. So a lot of times now we can use like our smartwatch or our phone to track our physical activity. But in poorer communities, they may have lack of access to this kind of fitness trackers or health apps. Also, some people might be concerned about the privacy issues or whether it's even effective or not if we use this on the social and environmental aspects. So, for example, in terms of children who are come from lower socioeconomic groups, they may have limited access to healthier foods. Or in terms of environment, when we tell parents let your children go outside and play. But parents are afraid because the outdoors might not be safe, there might be crimes and so on. Or they are afraid that their children will fall down if they don't have time to go out with the children to monitor their play. So because of these, children might lack healthier foods or physical activity. How about policy? So for example, government policies such as policies to monitor food advertising during childhood peak television viewing time, or even now because children might not be watching TV all the time, they might be watching their gadgets instead, their handphone and so on. And there are a lot of not just food advertising, but things like TikTok and YouTube that children might be watching that gives them a lot of screen time. So this might also influence children's overweight and obesity as well. What about culture? Now, different cultures and different attitudes towards weight status or body image or diet can influence our weight status as well. And if you will allow me a few seconds, I will tell you a story based on culture and attitude that can influence weight status. So for me, I am now a member of the Malaysian Association for the Study of Obesity. And previously, when I was younger, I was the honorary secretary of this association that we call MASO. And every year, MASO, we try to do a bit of community service where we do 3 days of what we call MASO camp. And muscle camp is basically 3 days of workshops and training for people who are overweight and obese, at that time, we chose people with body mass index of 27 and above, and we invite them to join this 3 days camp to learn how to lose weight. So there was one year when I approached one of our university staff. She was obviously obese, and I said, um, Kak, Kak or sister, that's what we call our people who are more senior than us in Malaysia. So I said, Kak, would you like to join our camp so you can learn to lose weight? And her answer really shocked me. So remember, I was young at that time, lack of experience. And I think that losing weight is good because being a normal weight can be healthier than being overweight. But her answer to me was, but I like to be fat. My husband loves me to be fat. He says that if I'm fat, he has more to hold. I don't want to be thin like you, like me, who was very thin at that time. So the answer really shocked me because I think that body image of people being slim is very good and being normal weight is healthy. But there are people who think that being fat is good. So that is just an example of cultural beliefs. Now, in terms of healthcare, next point, people in rural areas or from low income might have less accessible to healthcare services, and there might be more difficult to communicate with them about healthcare plans for them. In terms of funding, so we know every country has some actions to prevent overweight and obesity or to intervene for overweight and obese people. But do we have enough funding? Do we have enough resources to keep it on for a long time? So with that, I move on to when we should intervene for uh, overweight and obesity in order to prevent long-term risks for non-communicable diseases. So this chart shows you a concept that was promoted by Hasan and Luqman about 10 years ago now, but it is still valid until today. So on the x-axis, you can see is the life course. The further to the right-hand side, the older the person. And you can see here the green triangle, which says plasticity, which means how our body can adapt to the conditions around us. For example, to keep us healthier. So the older we grow, the less plasticity we have. And the red triangle at the bottom shows the detrimental effects of lifestyle changes and increasing mismatch. So if we have poor lifestyle, the older we grow, the more difficult it is for us to change our lifestyle, and the more difficult it is for us to change our body to make our body healthier. Okay. On the y-axis is risk. The higher it goes, the higher risk. So for example, if you look at this red line, which says high risk trajectory, means from birth until we are adult and older, we are already on a high risk trajectory towards having non-communicable diseases in our lives, for example, diabetes, heart disease, and so on. So if we intervene when the adult already has a disease, it's going to reduce the trajectory. So you can see the dotted red lines, but the reduction in risk is just a little bit. If you screen the adults who are not yet having any disease, it might be too late and you can reduce the trajectory, but by a little bit only. But if we start to take action when this individual is a child or an adolescent, at this stage, even if they are on a high risk trajectory, you can reduce it by quite a lot, okay, in terms of their risk. But if you intervene much earlier, for example, when the mother is pregnant or even before the mother is pregnant or during infancy, you can reduce them to a low risk trajectory, which is much better, which means that towards the end of their life, they will have less issues of non-communicable diseases. So keeping that in mind, I move on to share with you about some recent studies about managing obesity in school-age children. So I'm going to share with you a few examples, but one example in more detail and the other examples just very quickly. So this program is called Juara Sehat. Translated to English, it means Healthy Champions. So for this Healthy Champions intervention program, we targeted overweight and obese children in schools, and the study was considered a quasi-experimental study. We did a 12-week intervention. Children were aged between 9 to 11 years, primary schools in Kuala Lumpur. So we had 4 key components. We tried to modify their diets. We promoted physical activity. We did some classroom activities. And importantly, we involved parents as well as teachers in the tackling of this issue. So in the modules that we created, we have modules for children and modules for the facilitators, including the teachers who will facilitate some of these lessons. We have 6 main topics, which is, am I healthy? Cheerful and healthy chef, choose wisely for a healthy body, look at me, that's body image, and then we are active, physical activity, and fruits and vegetables are my best friend. So to kick off the event, we had an opening ceremony, we had talks from experts, and we had lifestyle forum, healthy lifestyle forum, we call it, where we had parents of the children coming to join the talks that we are giving to them so that they understand what their children are going to do in the coming weeks. And these are the modules, the activities. Some of them are classroom activities. We had healthy food pyramid and so on. Module 4, we had games. We had module 5 was physical activity. They go out and do their physical activity and so on. Right. Towards the end of the 12 weeks, we also did fun activities. So we had Senam Aerobic is aerobics competition. We had a mini chef competition. So we had competitions. We had a proper chef to come and do cooking demonstration. And we also had a fun run challenge. It's only 3 kilometers because the fun run is for the children only. Right. Then I also share with you, this is the flowchart of how we evaluated our program. So the program, the intervention was held from week 1 to week 12. And in week 1, we had workshop with the parents, as I showed you. Then we conducted the modules over the next 10 weeks or so. And then we had all the final events in week 11 and 12. And throughout this, before the intervention, we had pre-test. And after the intervention at 3 months, we did post-test 1 and post-test 2. The pink colored boxes are what we measured. And throughout, we did a process evaluation as well. So based on this, I'm going to share with you the findings of this 12-week intervention program to see if it's actually effective or not. So in terms of anthropometry, body mass index for H.Z scores, you can see that it went down a little bit and up a little bit, but it didn't go up as high as what originally was for the green line, which is the intervention group. And then the control group is the blue lines, which is in another school. So for the blue line, although they started out lower BMI, but it went on up and up over 6 months. So the difference between the two groups is significant, very significant. For waist circumference, the green line started out lower, it went down and it went up, but again, it didn't go up as high as it started out to be. And again, there was significant difference between the intervention and the control group. For body fat, similarly, it went down and up a little bit, but also that it was significantly different between the two groups. in terms of knowledge, attitude, and practice towards all these things that we have taught them, they improve their knowledge for the green colored intervention group. And for the blue colored ones, they also improve because in schools, they normally would have some lessons about this as well, but not as much as the intervention group. So for all three, knowledge, attitude, and practice, it was significantly different between the two groups. In terms of dietary intake, energy intake is significantly lower and it went down amongst the intervention group, but not in the control groups. And this is significant. But in terms of macronutrient intakes, there were no significant difference. In terms of physical activity, based on questionnaire, we couldn't see very much difference. And for pedometer step counts, it went up in terms of pedometer step counts among the intervention group. But because the control group also had to wear the pedometers, the number of step counts also increased. So there were no significant difference in terms of physical activity between the two groups. Now, based on that, our conclusion for the key findings of Juara Sehat is that there are significant improvements in terms of anthropometry, in terms of knowledge, attitude, and practice scores, and also overall energy intake. But there was not significant differences in terms of physical activity between the two groups. So, just because we conducted an intervention that lasted for 3 months and we evaluated them for 6 months, does that mean anything in the child's life? So what we want to know is, was the lessons that we taught them over the 3 months, is it sustainable? So 2.5 years later, we went back to the children. Actually, we went back to the children, the teachers, as well as their principal, to ask if the program that we conducted with them had been successful. Do they remember it at all? And these are the results. So we found that there were barriers to the sustainability. For example, if the children had no friends to play with, or friends made fun of them because they are overweight or obese, then it's a barrier. Or the children might be tired of the program already, or they are very busy, they are shy, they are lazy, or there are safety issues around their housing areas, and they might not have remembered or they have forgotten. So these are some of the barriers to sustainability. But we found out that there were also factors that facilitated the sustainability. And we start from the right. For example, the child's self-awareness that being mobile is good, being fit is good. It helps to increase their intelligence. They are more focused when they are studying. It makes them healthier. They look better. These are facilitators. And the home environment that encourage physical activity is good. Knowledge about food pyramid, knowledge about diseases, these are good knowledge. Continuing to practice what they learn in terms of physical activity and eating habits that are facilitators, as well as support. Support is very important from family, from teachers, from friends, and also the researchers. So these are all facilitators. So when we conduct an intervention, we always must think about, is this intervention sustainable or not? Will the children continue their practice or not? Right, that is our own project from UGM for Juara Sehat. Now I share with you a few Malaysian government initiatives for school children, and these include healthy school canteens management. They have guidelines, what foods can be sold, what foods cannot be sold. There were also guidelines to ban the sale of foods and drinks outside of school. So outside of school, a lot of hawkers will come during school break time or after school, and they will sell them unhealthy junk food, which are not allowed to be sold in school canteens. So with these guidelines, the local council can enforce that there are no motorcyclists selling hawker junk food and so on. Also for boarding schools, there are menu planning guidelines for them, And there are many other initiatives, for example, supplementary feeding program in school, school milk program, and all this, including HITS. Now, the next slide will share with you a little bit about this HITS program. It is a program that is in collaboration with Ministry of Education, along with the Nutrition Society of Malaysia. The objective is to improve nutritional status amongst children and to prepare and serve nutritional meals for school children and to increase the knowledge of school children about healthy eating and balanced diet. So for this, the project was piloted more than 10 years ago at only one school in Kuala Lumpur, but by 3 years ago in 2021, there were 72 schools throughout the whole country that have adopted HITS for their program. So this is a good sign that it is a successful program and is still growing today. Now, in terms of impact, so you can see here, I've shared with you two papers that are published from very long ago, but that's because the school supplementary feeding program began really long ago. And in this study, they found that the school supplementary program improved nutritional status of children from poor families. And it doesn't just improve nutritional status, it also improves school attendance rates. That means children who are poor would be more encouraged to come to school because they get to eat the supplementary feeding at school. And it also helped to improve their mathematics as well. So just to let you know that the school supplementary program is still ongoing today in all our primary schools in Malaysia. And for the school milk program, the study is also long ago, but the program is also still being conducted today. And what the school milk program did was it reduced the prevalence of underweight, stunting, and wasting over a 2-year period of time that the children were on school milk program. And it also helped to improve school attendance rate. So these are good signs. Although Malaysia today have a bit of lower underweight and stunting and wasting issues, but it's still there, and therefore the program is still being continued. Now, this last study is a recently published one. It's a school-based intervention program. It's actually referring to HITS. And what HITS has done is that in the intervention group, they managed to improve the frequency of breakfast, lunch, and dinner. So mainly the meal times are improved, and the intervention group had better physical activity and also cognitive performance of the children. And the project also managed to lower the body mass index for H.Z scores as well. Right. Now, for some studies that are not from Malaysia, so the first one is a school-based physical activity intervention project that was conducted in Slovenia in Europe. It managed to lower the BMI, and after 3 to 4 years, BMI reduced the most. So the time frame is about 3 to 4 years. Now, the other project that I'm sharing with you is an intervention conducted in China. They call it the Family, Individual, and School Program. So as you can see, similar to Juara Sehat, they involve the school as well as the individual and the family as well. They did health education, diet, and exercise. And the group that had intervention had lower odds of becoming overweight or obese compared to the control groups. And this is at 3 years after the randomized control study was concluded. So the BMI Z scores for intervention group is lower than for control group. So it's a successful program. In Jordan, which is in the Middle East, they shared a family-based lifestyle intervention on weight reduction. Again, it was successfully to reduce the BMI percentiles between the intervention group and the control group. And they also had improved dietary intake and physical activities. So basically, all intervention programs that are conducted at schools with school children and their family are successful. So here I would like to go to my conclusion side. with a few take-home messages. I think around the whole world, as we can see from the data shared with you, the prevalence of childhood obesity is rising. And that includes countries in Southeast Asia like Malaysia and Indonesia. And if we want to tackle obesity in school children, we need to consider educating them in terms of healthier nutrition and physical activity, healthy lifestyle, and so on. But just tackling the children alone will not be able to solve the problem. We will need the school, the teachers, the principal, the parents to champion the program and to continue the program after we have concluded our study. And that involves also, on a bigger picture, collaboration with government agencies, public health experts, healthcare professionals, education institutions like the schools, as well as community organizations. The more people who are involved in tackling childhood obesity, the more impactful programs we will have. And hopefully with this, we will be able to maintain our childhood obesity targets as per the global nutrition targets, which is to maintain the number. We are not even trying to reduce because it's almost like impossible to reduce for now, but hopefully with a lot of effort from everyone, it can be done. With that, I would like to thank you for your kind attention. Do we have time for question and answer?
Thank you, Prof. Paul. Very important topics that we learned a lot from your lecture. That it reminds again to all of us there are some unmodifiable and modifiable factors to obesity, and I absolutely agree, and I think all of us here agree that we need effort, multidisciplinary effort, because of those factors that influence the obesity. And Prof. Paul, maybe if the audience have questions, maybe you can keep that with you. We will have that later on. But I also have question to Prof. Paul. You mentioned all of the sectors that need to work together to tackle the school age obesity. How about the industry, food industry, commercial stats?
Yes.
I think that's a really challenge, but we will keep our discussion later on, Prof. Paul. Okay, so we'll move to our next speaker, Ibu Mutiara. Is she here? Hello, Bu Mutiara, are you there?
Hello,
Hi, how are you?
I'm good, thank you.
Where are you? Why you are not here together in this room?
I'm sorry, I can't. I have a conflicting schedule.
All right. Okay. Well, anyway, thank you very much for joining us. Before you deliver your lecture, I would like to introduce you to our audience here. We have audience here offline and also online in China and some other countries, I believe. So, Ibu Dr. Mutiara Tirta Prabandari Lintang Kusuma.
Yeah,
You have such a long name. All right. She is our faculty member from Department of Nutrition and Health here from Universitas Gadjah Mada. She earned her doctoral degree from Kansas, ya Bu ya. Kansas, University in the USA. Dr. Mutiara has made significant contributions to the field through her extensive publication and research. She is known for her work on understanding and addressing stunting, a critical public health issue. Her recent works include co-authoring the study Memahami Stunting, so it will be Understanding Stunting in English, and dan upaya mengendalikannya, and the effort to address it, and various other publications related to public health, nutrition, and policy. Well, another research interest of her, she also focused on HIV/AIDS, nutrition, and sexual reproductive health, emphasizing qualitative research methodologies. So this morning, Ibu Mutiara will share with all of us about food security approach in managing stunting in Indonesia communities. Bu Mutiara, time is yours.
Thank you. Okay, can you hear me? Do you hear me? Do you hear me okay or no?
Very clear, Bu.
Okay, okay. And what about the slide?
Yes, we can see
Okay.
it clearly.
Okay, so I'll start. Well, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. It's an honor to be invited to talk with you in this summer course program on interprofessional healthcare and share some of my experiences working in the field of health stunting. So, as has been introduced by the MC, my name is Mutiara Kusuma. I currently work as a lecturer at the Department of Health Nutrition, Faculty of Medicine, Public Health and Nursing in Gajah Mada. I currently also work as a project consultant for the Office of the Vice President of Indonesia on stunting reduction. And the topic that I'm going to share with you today is stunting reduction acceleration program in Indonesia, focusing on the food-based security approaches. Food security-based approaches. Okay, to begin with, the government of Indonesia has implemented various policies and programs for years to prevent and control malnutrition among children, including wasting and stunting. However, the National Basic Health Research, we called it RISKESDAS in 2018, which is a 5-yearly health survey collecting cross-section data at district level, reported that the problem persisted ever since the first wave of the survey. So you can see here from the 2007 to 2018. Now we have the 2023. As can be seen from this graph, with an average reduction rate of 1.35% per year over the past decade, the prevalence of stunting remained unchanged. It didn't really change significantly from 2015 to 2018. And data from the 2018 survey showed that the prevalence remained high at 30.8%, the sum between the severe stunting and stunting. And it is classified as public health concern according to the cutoff of WHO. And the 2018 survey then served as baseline. So this survey is served as baseline for the current stunting initiative. So otherwise specified, if I mention previous data later in my presentation, I'm referring to this survey, the 2018. Okay. The 2013 survey, however, reported that there were large disparities in stunting prevalence between and within provinces, as you can see here. So the first graph shows the prevalence of child stunting in Indonesia by province, and then its breakdown into each district in each province in 2013. And we can see here that there was a large disparity in stunting prevalence between and within provinces, with the highest prevalence were mostly provinces in the eastern part of Indonesia alone. Okay, the eastern part of Indonesia. Moreover, it was unclear whether current approaches to reduce stunting align with the scientific evidence in Indonesia. So mostly our data and evidence were gained from global research, not from Indonesia. And since 2018, stunting has been discussed in several high-level national meetings by the line ministries and also the vice president, and it was decided as a national priority program, considering its long-term and severe consequences. We found several studies reporting stunting causes cognitive deficit, increased vulnerability to illness and loss of productivity, which in turn limits economic development and increases poverty rate and social gap. The PISA OECD reported that Indonesia ranks 64 out of 65 countries in IQ score among children, so it is really bad. With this effect on education and economic aspects, stunting also perpetuates intergenerational poverty, and we found that the World Bank estimated that stunting led to 20% less earning in adulthood, and it caused GDP loss by 2 to 3% per year, which equal with 260 to 390 trillion per year. Well, I don't know the current exchange rate with dollars, so you may want to check that in Google. So With that in mind, the government of Indonesia developed an integrated and convergent approach to reduce stunting. Using this analytical framework here, the government of Indonesia focuses its effort on to improving the issues related with household and family factors, related with complementary feeding or child feeding in general, including breastfeeding, improving infection and access to basic vaccination, as well as addressing the community and societal factors here that considered as the root cause of stunting. To ensure that the initiative is developed based on scientific evidence, the government asked S.Gz, or the Global Alliance for Improved Nutrition, to conduct a systematic review and meta-analysis of published work from Indonesia to determine the cause of stunting in children in the country. And they found that stunting is associated with gender premature birth, short stature at birth, non-exclusive breastfeeding, short maternal height, low maternal education, low socioeconomic status, lack of access to proper hygiene and sanitation facilities, poor access to clean drinking water, poor access to healthcare, and living in rural areas. This review also reported that there was limited evidence to determine the contribution of poor education, society and culture, agriculture and food system, and water and sanitation, and the environment to child stunting. For example, here, the graph showed no correlation between household food expenditure, which is a proxy for dietary adequacy for certain food or food groups, for grain, food stunting. However, there was evidence here on the relation between household spending on animal source food on stunting. In addition to the GAIN study, a comparative analysis with global evidence on what works in improving nutrition among mother and child showed that the government of Indonesia had been long implemented 10 major nutrition interventions. The interventions ranges from providing optimal maternal nutrition during pregnancy, infant and young child feeding, micronutrient supplementation in children at risk, and management of acute malnutrition. So this is in line with the report of Lancet on maternal and child nutrition in 2008 and in 2013. Lancet also reported that those interventions as life-saving and cost-saving intervention. As you can see here in this table, the breakdown on the estimate of number life-saved and cost cost per life year saved for each group of intervention. Divided into 4 optimal maternal nutrition during pregnancy, infant and young child feeding, micronutrient supplementation in children at risk, as well as management of acute malnutrition. So, considering that the program is actually supported by evidence and is actually considered as life-saving and also cost-saving initiatives, why did the program fail? Why did stunting remain prevalent despite the various interventions being implemented for years and years by the government? So another series of studies from the World Bank and partners show that while in fact stunting reduction requires multifaceted and complex efforts, stunting intervention in Indonesia were mostly carried out by the health sector. This does not align with Lancet estimation that 70% of stunting reduction should be carried out in a sensitive manner by other relevant sectors such as agriculture, women and empowerment, infrastructure, education, social and economy, as well as the water and sanitation. In fact, nutrition-specific approaches performed by the health sectors contribute to short-term solution and only 30% of the stunting reduction attainment goals. Other factors contributing to the lack of results in stunting prevention are highly fragmented approaches due to poor coordination between relevant line ministries and stakeholders, lack of awareness from the national and local government, leading to lack of commitment and political support needed to achieve the attainment goals, as well as insufficient program implementation in terms of program design, delivery, quality coverage, targeting, monitoring, and evaluation. To put it simply, we can say that the previous stunting intervention have no clear framework in Indonesia and very fragmented, just like this picture, which hinders significant progresses and achievement to meaningful results. Everyone just work by themselves and, lack of coordination and convergence. In fact, studies reported that the integrated and convergent approaches, like the second picture here, is necessary to accelerate progress in stunting reduction. So we need to work together. And to rectify the problems, the National Team for Poverty Reduction Acceleration had initiated series of high-level meetings between relevant line ministries and government agencies, as well as experts and development partners regarding stunting prevention. As a result, in 2018, the national strategy of to accelerate stunting prevention has been implemented with several key points, including the establishment of the 5 pillars of stunting prevention. So this is the 5 pillars of stunting prevention. Pillar 1, commitment from the national leader. Pillar 2, national campaign focusing on improved awareness, behavior change, political commitment, and accountability. Pillar 3, convergent, coordinated, and consolidated national program with regional government and committee members. Pillar 4, nutritional food security policy, in which we are going to go much deeper in that. And then Pillar 5, monitoring and evaluation. So this 5 pillar of stunting prevention is actually an intervention framework that has been discussed between the national policymaker and other relevant stakeholders, which is developed in accordance with the global best practices and scientific evidence. If you are interested in understanding on how we come up with these pillars and selections of relevant interventions, you might want to read this book. But this is only in Indonesian language, so that's the English version, I guess. Okay, so we will go deeper into the food security-based approaches. The framework in which the government works in improving food security to address stunting is developed according to the basic tenets of food security as designed by the FAO and the partners. It comprises of 3 aspects of food security, including food availability, food affordability, and access to nutritious food. Now, as part of the tagging and tracking of programs, so the government do the tagging and tracking of programs to see whether the program that should be contributed to stunting reduction is actually implemented well. The government identifies several existing programs under the pretext of food security-based approaches to stunting. So the unique thing about the new initiative of food of stunting that currently implemented by the national government is that we don't really have new programs, we don't really have new initiatives, but we strengthen what we already have. So as part of that initiative, the government identifies several existing programs under the pretext of, food security approaches. This includes the provision of food assistance for poor and near poor household. Previously they call it BPMT, and now they call it sembako. It's actually a huge changes from providing food in kind into providing non-cash food assistance. They call it now sembako in a shape of a conditional cash transfer. This program is implemented by the Ministry of Social Affairs. And then on the other hand, the Ministry of Agriculture here perform nutritious food security program and program to increase access to homestead food for consumption or extra income called KRPL. So here, called Sustainable Food Home Area. In addition to that, the Ministry of Health, Ministry of Trade, and the National Food and Drug Agency, they also work together on providing fortified staple foods for the targeted population, as well as providing nutrition food product information for the community. The KRPL or the P2L, or this program one, the Sustainable Food Home Area, include home gardening, raising poultry and small animals, as well as developing cultivated crops. And the crops that crop cultivation here is aimed to meet nutritional needs, and livestock are considered a source of extra protein and also extra income for the family. These activities are implemented through community groups and women farmer groups, which help homestead cultivate diverse crops and then support homestead demonstration and support group farm plots, as well as improve gender relation and women empowerment. So there's many added benefits from the program. And then for the national staple food fortification, this program is supported by the national legislation to fortify staple food with micronutrient, including vitamin A or provitamin A in the content in palm cooking oil and wet flour. And there have been national regulation for registering processed food and for labeling the nutritional value of processed food. to educate the community members. And as a result, 227 types of products were voluntarily fortified with micronutrients by the industry in 2019. The Ministry of Industry introduced improved flood standards in 2018 to meet WHO recommendation for the allowance of iron compounds. And mandatory fortification of produce resumed on January 2nd, 2021. While for salt, it has been mandatory fortified in Indonesia since 1994 with iodine. In terms of biofortification, the government of Indonesia has also biofortified zinc rice, locally known as the zinc. The idea of improving access to nutritious food and food security at family level through household animal husbandry and home gardening was actually derived from global evidence. One of it is this one, in which these two approaches, the home gardening and animal husbandry, are found to be effective effective to improve dietary intake and thus correcting nutrition problems in family. Other studies also reported that this program, when combined with nutrition education and health promotion activities, may increase its effectiveness to stunting reduction as an added benefit to the program, because traditionally in Indonesia, women are responsible with providing food for the family and cooking. So this program of providing household animal husbandry and home gardening also empower women economically. However, the formative findings from the new stunting initiative in Indonesia found that KRPL has shown limited impact on child nutrition, particularly stunting. Some positive results were found in Bali and Central Java, where villages and districts have supplied crops, vegetables, fish to families with stunted children. The report concluded that the impact of this intervention on stunting reduction is still unclear and require further evidence. You can see in the table here that the effect of KRPL across the year is very limited in terms of improving daily average consumption of calories from vegetables and from fruit, as well as in correcting underweight children and protein consumption. This data was taken from online survey among program manager and stakeholders, as well as operational staffs of the program. They were asked to determine whether the program is able to increase access to nutritious food and increase food security. While most of them answered that this program has increased well in terms of access to nutritious food and food security, some a quite large percentage of the population of the study say that the program has not increased the situation significantly. In fact, when asked to rank the top 3 most effective nutrition sensitive intervention according to the online survey, to compare between WASH program and then the insurance program, the toddler family development program, and then the cash-based transfer program, they ranked that the sustainable homestead food garden as the 5th rank, which means that it's not that satisfactory in terms of improving access to food security and improving access to better nutrition for the family. However, findings were very limited, which indicates that also there's very limited understanding among the community members and among the staffs involved in stunting-related activities about the program. There has been also limited evidence in the policy in the previous document by way of increasing access to nutritious food and food security for targeted populations. So they concluded, the formative report concluded that efforts to secure food at the family level through sustainable homestead food garden were unsuccessful. So there are several challenges that causes the situation in which hinder the ability of the program to attain the goal of contributing to stunting reduction efforts. The first one is choices and access to affordable, nutritious, and quality food are still limited for most Indonesians. This is the problem related with supply chain management, as well as supply chain management in terms of the supplies that needed to perform projects related to home gardening and animal husbandry. And then the second one, the community is not yet fully sensitized to the fact that the home gardening and the animal husbandry project is actually only the start, only the beginning, and the community itself should continue the program even after the program termination. So to ensure sustainability of the results of the program. And then the third one, the challenge is related to the lack of skills and resources to implement good animal husbandry, manufacturing, and handling practices, as well as home gardening among community members or the practice team. There is also a problem related with lack of knowledge and skills to implement the practice of dietary diversification and adoption of nutrition of well-nutritious diet among the targeted group. So they don't know what to choose among the food that are available in the market. And lastly, the COVID-19 pandemic, which is the main culprit on why the program doesn't reach the optimum impact of stunting reduction, is that COVID-19 pandemic increased the number of food insecure households. So it added the burden of the government to deal with the stunting root cause. And then it causes also changes in program delivery and budgetary allocation that makes the programs needs to readjust and needs to be refocused. So this is the end of my presentation today. I hope that you can get something from my presentation. I'll be happy to take any question from you. Thank you.
All right, thank you, Bu Mutiara. Can we give applause for her? All right. Dr. Ruhaya, if you might allow us to have discussion first, because Prof. Po, I just have information that she cannot join us until the end of our session. So if you don't mind, we'll have discussion. Okay, thank you so much. All right, Prof. Po, are you there? Is she here? Right. Well, Bu Mutiara, thank you very much for your lecture. That I just also aware that stunting mostly carried out nowadays only by health sectors. Yeah. While you are saying that it should be multifaceted effort, and every sector should also have put effort to address the stunting. And at the end of her presentation, she mentioned about the lack of knowledge of the community about the nutritious food, and also the situation itself about stunting will affect their life. And also, this is, I think, problem that quite, I don't know, challenging the access to the nutritious food, the affordable nutritious food for our community is quite challenging. Not only in a rural area, it also happened in urban somehow. Yeah, because of the economical status. All right, Bu Mutiara, Prof. Po, are you there? We have, I'm sure one of our audience here have question for Prof. Po. All right. Yeah. All right. Okay. Yeah. Yes. All right. So we are not here. We do not hear anything yet from Prof. Po, but we hope she will join us soon. But you may give your question now, and our team will note that your question and give it to Prof. Po, and hopefully she will read it from the chat box, right? Do you have microphone there? All right, good.
All right, so my name is Muhammad Darwishiman and I'm from UPM, Malaysia.
How should I call you?
Darwish.
Darwish.
Yes.
Okay. Hi, Darwish.
Hi. Okay, so my question for Dr. Po is actually about the unmodifiable factor for being obesity, like the gene mutation or polygenic obesity, or maybe syndromic obesity, for instance. And if the particular person have already do enough physical activity and eat healthily according to their nutrient needs, but still in obesity state, do these people be prone to obesity-related diseases like those NCDs? And if yes, will be the best intervention for them if they are still pediatric, as if they will also prone to those obesity-related diseases. And my second question is related to school supplementary feeding, or also called RMT, if I'm not mistaken. Based on my experience, because I'm also from Malaysia, I saw that especially in rural area, school often serve energy-dense food rather than nutrient-dense food. Those food actually, from my view, quite low in protein, as it targeted for low-income population that might have low intake of protein. So, from Dr. Po's opinion, how do we actually cater this issue, as doesn't it will increase the obesity rate if we focusing on energy dense food rather than the nutrient dense food? Thank you.
All right, thank you, Darwis. I will check it again with Prof. Po. Is she there? Because I don't think I can deliver your brilliant questions to Prof. Po completely. But I got your point that the first one is about the unmodifiable factors. Of course, we cannot just ignore it. We also need to address that. How about them who has that factors? Also related to the NCDs, because they are on risk to the NCDs, right? So what your question is, what is the best intervention for them, this population?
Yes,
right?
actually my question is, if they already like try a balanced diet and also have do enough physical activity, are they still prone to
Okay.
obesity related if they are still in obesity state?
I see, right. Okay. All right. Prof. Po is not yet here, so hopefully she will address your question later on. Well, worst case, if she is not here until the end, we will keep contact with her and make sure your questions is addressed by her. All right. From the audience, is there any other question either from for Prof. Po or for Bu Mutiara? Yes, please. Do you have? Yes, you have microphone there.
Okay, my name is Catur Septian Rivaldi. So thank you for the.
I'm sorry, who are you again?
Catur Septian Rivaldi.
Catur. All right.
From Agricultural Technology UGM.
Okay.
So, I will ask to Ibu Mutiara, what's your opinion about makan siang gratis?
All right.
That is the program of Prabowo Gibran that this is effective or not?
Right.
To face the stunting and yeah, that's it.
All right. Thank you very much, Chatur's very good observation. We all of us, well, for our fellow from Malaysia, if you are not familiar with the current situation in Indonesia, that our elected president have program makan siang gratis, free lunch for everyone. So Chatur asked Bu Mutiara, he and I think all of us wants to hear from you. What is your opinion? What is your view about this? Will this be a good program to address stunting problem in our community?
Do I respond now or later?
No, next year. Now.
Okay.
Yes, please.
Wow. Okay.
Yes, please, Bu.
Okay. Okay, thank you, Catur, for the question. It's a fully politically loaded question, so I have to be very careful because lecture's supposed to be neutral here. Um, with the free lunch program, well, to say whether the program will be effective or not, then we have to first implement the program and then we measure the effect before and after the program. But talking about effectiveness is not enough because, actually the efficacy of the program in improving child nutrition and improving cognition and other aspects related to child education is actually profound. It has been studied. The global evidence has been there, and you can read it in journal. Some countries has been successfully implemented the program, like Japan, South Korea, and many other countries. But in Indonesia, the challenges will be on, given our country is an archipelago, and then we have, problems with different types of food accessibilities in each places. So we're actually in the middle of redesigning the program in order the program to be well implemented. So my colleagues and I in our department are actually part of the how to say design, someone who were asked to redesign the program because there are several things need to be adjusted in order the program to be efficient and effective, including the design and how to deliver the program, like what kind of food should be provided for the children, how to cook the food, who will be responsible with the cooking, ensuring the quality and the safety of the food that is provided. But when you ask me question whether the program will be effective on reducing stunting, um, originally the free lunch program in other countries is never aimed at correcting stunting. It's more like correcting malnutrition in general, whether it is underweight or wasting. Stunting is included actually, and also obesity, and then to provide nutritious food for children, to support their cognition process and education. But for stunting, it is difficult to say because stunting is, well, some people might say that before 2 years, before the children reach 2 years old, it's still reversible. But actually, it is hard to reverse the effect of stunting after it happened. So we can't really say whether the program will be effective on reducing stunting. It will be helpful if it's performed at scale, if it's performed well. It will be helpful on correcting malnutrition. But stunting per se, we should really study it very well on determining if the free lunch program is beneficial on reducing stunting. Because after 2 years old, all that we can do to the stunting, to children with stunting is actually providing stimulation, education, enough stimulation for their growth and development. So that's that. There's so many things about the free lunch program. It's still under
Under
construction.
development.
Yeah.
And you
There's so
are
many things
part
that we
of the
need to.
team, yeah, Bu. So you will be part of the team designing the
But
program.
I am neutral.
No, yeah,
I need to
yes.
find out.
Later on, I will just want to say that to
Yeah.
you, good luck and put your best effort, and make sure,
So
like what Darwis concerned, do not put only energy dense food to the
yeah.
children, right?
Yep. We
Okay.
calculate like the amount of calorie that should be provided and then the types of food that should be provided. Like previously, they really want, the government really want to put milk on the menu, but we say that milk is highly perishable and it's hard to store milk in some places in Indonesia. Like sometimes we need refrigerator, and in some places in Indonesia, it's really hard to ensure, the electricity remains on
Yeah.
all the time.
Yeah.
Yeah. And there's also a problem with lactose intolerance in Indonesia, many things.
Exactly.
So, yeah.
Right. And also make sure what kind of milk you want to give the children. Milk with
It's actually,
a lot of sugar in it, or well,
yeah, exactly.
it's well known. We all know that our milks, some of our milks have sugar on it. So
Yeah.
yeah, okay.
Yeah.
So
And
yeah,
it's
so
actually a
many
large
things
team,
that
so
we need to
yeah.
think about and prepare. Yeah, for the
Yeah.
effective, efficient, good free lunch program. Ya kan, Catur? Right. All right. Thank you, Bu Mutiara. Is there any other question, maybe from our fellows who join online first? Hello, anyone there who join online? How many participants do we have right now join online? Hundreds? What? Thousands? No. All right. Guys, do you have any questions? No? All right. So we move to our offline audience first. Yes, please. Okay.
Good morning. My name is
Good
Aulia,
morning.
and I'm from
Aulia.
and I'm from Bachelor of Dietetics in Universiti Putra Malaysia. So I would like to ask a question to Bu Mutiara. As we know, that Indonesia is dealing with triple burden of malnutrition, especially micronutrients deficiencies, and the government has already the program which is about national staple food fortification. Is there any data that discuss the impact or outcomes from the program that reducing the issue? Thank you.
All right. Thank you, Aulia. Bu Mutiara, do you get the
Yep, okay, good question.
point of Aulia's question?
Yep, I get
All
it.
right.
So yeah, okay, yeah, we have problems with triple burden malnutrition. So it includes overnutrition, undernutrition, as well as micronutrient deficiency. We currently focuses more onto the overnutrition and undernutrition, and the thing is the evaluation that we perform, it's actually performed by the UNICEF. Um, they were not how to say, they were not dissecting program one by one, like they um, they evaluated as a whole initiative. So there's several interventions encompassing both nutrition sensitive and nutrition specific intervention within the initiatives. You might want to maybe check the national strategic document. It has several, and the evaluation was conducted as a whole. So whether we are successful on correcting the problem with malnutrition after the initiative took place. Talking about overnutrition, we don't really have data on that, but we have data on malnutrition, mostly on wasting and stunting. The formative findings from, or the preliminary findings from our study, because it's still ongoing. The initiative is actually will end this year, according to the political year again. So we found that after 5 years implementation of the new initiative of stunting reduction prevention acceleration, we can say that we were successful to on reducing the stunting. Although we, looking at the data in 2023, we don't really achieve the target of reducing by 14%. So our previous the baseline, which was in 2018, was actually 30.8% for stunting, and then we aim to achieve 14% by 2024. But currently we have 20 something. I forgot the exact number. But with the micronutrient deficiency, we don't really have data because we're now still focusing on the malnutrition, the undernutrition issues, particularly stunting. But we have to understand that the government used stunting as a banner for their for their plan and for their objective to improve livelihood of the community members, of the people in Indonesia, through health and nutrition. So I think later we will have like a much deeper analysis on dissecting whether each program, like how many percentage of each program contribute to like stunting reduction or other intermediate features, outcomes features such as micronutrient deficiency. I hope that answers your question.
Is that answer your questions? Do you have any following up question? You should have. No? All right. So by the end of this year, hopefully, Bu Mutiara, we will have the data, and we'll see if that program efficient enough, right?
Yeah, we are actually still far from achieving the target actually. So the target is 14% for stunting. For stunting, it's 14%. And for now we have like 20 something, so it's still far. That's why my current job is on devising and revising the new national strategic as well as the new government decree, presidential decree on stunting reduction. So we want to carry out the program even though the government changes.
Wow, what an important job, Bu Mutiara. We hope you luck. All right. Is there any other question? Not yet. Okay. If there is no other question from our audience online, not yet. Or maybe in the chat box, can you help me to see whether there are some questions? Nope, not yet. All right. Okay. So if you allow me to continue our session, we will have our third speaker. Dr. Ruhaya Binti Hasan. Thank you very much for joining us here offline. Finally, we have someone here together with us. Dr. Ruhaya will talk about conventional method to mobile application on nutrition and oral health prevention of caries. But before that, I would like to read her bio sketch to all of you so you will know her better. Dr. Ruhaya's research primarily focuses on nutrition and public health areas in which she has published extensively. She has authored numerous research papers and articles, contributing significantly to the academic community. Her expertise in this field is complemented by her involvement in various research grants and projects. Additionally, Dr. Ruhaya is recognized for her work in promoting public health nutrition, earning accolades and recognition with her academic and professional circles. Her ongoing commitment to research and education continues to impact the field positively, making her a prominent figure in dental and nutritional science at USM. Welcome, Dr. Ruhaya. I invite you to come to the stage and deliver your lecture. Please welcome Dr. Ruhaya.
Okay, Assalamualaikum and a very good morning to everybody. First of all, I want, can I stand up to give you a speech? All right, okay, thank you. Because I prefer to work when I giving a lecture, right? Okay, first of all, I want to thanks to the community because invite me as an invited speaker for this summer UGM summer course 2024. As mentioned by the what's your name? Ms. Arian just now. I'm Dr. Ruhaya from USM, University Science Malaysia, not in Kuala Lumpur, but in Kelantan. But I noticed that a few participants from Malaysia just now, from UPM, right? But then they are in KL, but I'm in Kelantan, not in KL, not in the urban, but I'm a small city in Malaysia, in Kelantan, right? All right. So we already heard about the lecture about the obesity and stunted just now, right? So now we divert our mind instead of talking or thinking about the obesity and stunted, but then we move to oral condition. Is it okay? Yeah. All right. So we move to caries. Yeah. Do you know about the dental caries? Yeah. Oh, sorry, before I start our lecture, I'm sorry about the topic that mentioned by the moderator just now. I changed my topic to sugars and caries prevention instead of mobile application because I'm informed that I need to prepare the question. Right, so I think it's very difficult for me to prepare the question from the research. So that's why I'm changed my topic to sugars and caries prevention, so that I can share my knowledge with you, because you are now come with a different background, right? So this is maybe a new knowledge for other course of dentistry, right? Okay. So comes to about the caries, yeah. Caries, we know that the most important factors for caries development is sugars, is it? Right. And then according to prevalence of dental caries in Malaysia, it shows that about 30 to 66% of the preschool children having caries, right? And in one of my study in Kelantan, it shows that about 90%, 90 to 6% of the preschool children in Pasir Mas district and Tumpak district having caries. You know, it's very severe about the caries problem in, especially in Kelantan. Yeah, because in Kelantan, people in Kelantan tends to eat a sweet food and beverages as compared to other states in Malaysia, right? All right. So we know that caries is very, very dangerous, right? Because while children having a caries, they can affect their social and you know, and their healthy too. They cannot eat well, yeah. They cannot speak well. They cannot sleep well, right? Okay, move to our lecture today, right? All right. Okay, this is my objective of my lecture today. I hope that towards the end, you're able to explain about the effect of diet or sugar or to the tooth, and describe about the role of diet in etiology of dental caries, right? And also I will share with you some classical study, yeah, to prove that sugars really having a significant relationship with the caries development, yeah. And also the classification of sugars. We know that we always talk about the sugar, but maybe we do not know the classification of sugars, right? And also what's the factors influencing the carcinogenicity of foods and drinks that we take every day, and also how about the dietary recommendation to prevent the dental caries. Yeah, we know that to prevent the dental caries, they have a ways to prevent it, but how to prevent it? Can we prevent it through our diet, or also can we prevent it through effective toothbrushing techniques, right? Okay. Here? Where should I point it? All right, okay, sorry. All right. So according to WHO in 2018 had identified that the role of diet and nutrition in oral disease development, namely dental caries, periodontal disease, and oral cancer, means that these three dominant disease about the oral is caused by the diet, right? And also it does have impact towards various oral condition and pathologies, including delayed tooth eruption for the children. Yeah, for those for those pregnant mothers who are not have adequate nutrient during the pregnancy, the baby will face with the delayed tooth eruption, right? That's why it's very important for the pregnant mothers to take care of their diet, to get the balanced diet, to ensure that not only the fetus growth well, but also to the mothers, right? And also development of enamel defect, salivary gland dysfunction, and also molar mucosa pathologies. Right, so this is very important for us to understand the impact of nutrition toward oral health, right? Because this can, it can affect the dental caries. Then when we know how severe the dental caries problem, so that we can plan the health promotion program to prevent that dental caries. Yeah, and in my study too, I did a lot of study on prevention of dental caries, but I'm not share in this summer course. Maybe next time. Yeah. Okay. As we know that the diet is dynamic relationship between oral health, yeah. So the diets may affect the integrity of tooth in terms of quantity of teeth, and also salivary pH. You know the salivary pH, whether it's acidic or not in our mouth, it can also affect the caries development, yeah. And also composition of saliva, what the nutrient content in the saliva, and also the plaque pH. The caries development is really defend the plaque pH level in our mouth, right? And foods such as sugars and other fermentable carbo are being hydrolyzed by the salivary amylase in our mouth. Yeah, can provide the substrate for the action of oral bacteria, which is in turn will lower our plaque and salivary pH, right? So before we go further, there's a few terms that I need to introduce you guys. Yeah, this is about the term in nutrition. Because I am a nutritionist, but then my body in part in dental school, so I need to integrate the nutrition and dental area. So I need to know about the nutrition per se, as well as nutrition and oral health. Right, so this is the nutrition terms that I need. I think this one is a common term that you already know about this. But this is maybe a new terms that you need to know, right? This is the terms that I will use during my lecture. The acidogenic term is the foods or beverages that readily cause a drop plaque pH to less than 5.5 within 13 minutes. Mean that if you eat this type of acidogenic foods, it can cause the acidic situation in your mouth, and it can cause either dental erosion and also dental caries, right? And the second one is cariogenic. Cariogenic food is very harmful. Yeah, the foods or beverages that contain fermentable carbo that can be metabolized by bacteria to cause a decrease in plaque pH to less than 5.5, and it can result the demineralization process in your mouth, right? And also ultimately it can cause a caries development, right? The third one is anti-cariogenic. What is the anti-cariogenic? Anti-cariogenic is the foods or beverages that can prevent the cariogenicity activity, yeah, and when eaten before, and acidogenic products, yeah. And then the good food in oral health is the cariostatic food, yeah. That's why in diet counseling we always need to advise our patient to take the cariostatic food, because to prevent the dental caries, yeah. What is the cariostatic food? Cariostatic food is foods or beverages that cannot be metabolized by dental plaque bacteria within 30 minutes and do not cause a drop of salivary pH in your mouth. Yeah? Okay, that's why the cariostatic food is very important in caries prevention. Right? So far, do you understand? Yeah. Any question? No question. All right. Thank you. Sorry. Yeah, my dear. Carcinogenic. Carcinogenic is the carcinogen that can cause a cancer. No, that's about the cause of cancer, cancer disease. This is about the dental caries. Yeah. Okay. No problem. For me, I'm happy if you ask the question during my lecture, so that if you do not understand, then immediately you understand after that. Right? Yeah, what's the food for this term, right? So as I show the pictures here, the type of cariostatic food is some sort. The example is some sort like a meat. If you eat meat or chicken, yeah, it's type of cariostatic food. The cariogenic food is any food that is very sweet, and it can stuck between your teeth. For example, donut, ice cream, sweets. That's a cariogenic foods. Yeah. So the acidogenic foods is the foods that some sort like the sour fruits. For example, mango. Yeah, it can cause a dental erosion. Yeah, the anti-carcinogenic is to prevent the carcinogenicity of the food. For example, cheese. Yes, it can buffer your saliva when you eat the anti-carcinogenic food, right? Okay, so everybody understand now? Huh? Can I continue? All right, thank you. Oh, sorry. Oh, sorry. All right, it should be 10. Okay, so according to Newborn in 1989, say that diet refers to customary allowance of food and drinks taken by any person from day by day. Thus, the diet may exert an effect on caries locally in the mouth by reacting with the enamel surface and by serving a substrate for carcinogenic microorganism. Right? So how the caries process is, how caries development will happen in our mouth. So it actually, dental caries is a dynamic process. Yeah, it's a dynamic process that involves demineralization and also remineralization. So what is demineralization and remineralization? Anybody know about that? Do not know. Right. Just imagine our teeth like a block. Yeah, a block. When you drink isotonic drink, for example, is acidic or not? Acidic as well as how about the sugar content? Very high, right? So when you drink that drink, yeah, imagine our teeth like a block just now. So with the acidic drink, with the pH less than 5.5, the mineral inside our teeth will go out. That's we call as a demineralization, right? Then after that, when you eat for example, the karyostatic food, cheese just now, the cheese is rich with calcium, phosphorus, and etc. So that mineral will replace again the empty block just now. That we call as a remineralization. Right? Understand? Okay, that's in the dental punya, in the caries process development, right? Okay. Okay, we go to etiology of dental caries. What's the factors that can cause a dental caries, right? So there's 4 factors of dental caries, which is first is microorganism. Yeah, they must have the microorganism inside our mouth to ensure that caries happen. The second one is substrate. The third one is time. And the fourth one is health and also teeth. Health is your teeth, right? Okay, let's say that one of these etiology absent in caries development. Did caries will happen or not? This will happen or not? Still happen? Let's say no substrate, you didn't eat anything. So how about the condition in your mouth? Whether is it acidic or no? Neutral. Yeah? For caries development, we need these 4 factors together, work together. Is one of the factors not here, the caries will not happen. Alright? Okay. So the roles of carbo in caries. While talk about the caries, you need to remember about the carbohydrate and also the sugar, right? So this is the role of carbo in caries development. When we eat, just now you have the coffee break. What you take for your coffee break just now? Cheese, coffee, and I can see that. What is that? Donut? Cake? Biscuits? Something delicious? Is it that delicious? Is sweet or not? Sweet. Some say sweet, some say not. Sorry. Okay, but that is that food that you take just now is the content is carbo, right? So the food containing fermentable carbo will go to carbohydrate fermentation by plaque bacteria in your mouth. That bacteria can produce the acid. Then the acid will cause the demineralization for the enamel surface. If the exposure is long, is more than 30 minutes, then if the exposure is frequent, it can cause the dental caries. Alright? Okay. What happened for the food when we eat? You need to remember about the Stephen curve. This shows what happened when we eat every day, every time. Right? When we eat, okay, for example, just now, curry puff or donut, for example, yeah, the blood pH in our mouth, well, falls within 2 to 5 minutes when food enter to our mouth, yeah. Then after that, it will remain at the low level for 15 to 20 minutes and return to a normal resting level after an hour after that. Means that if you have 5 sweets, right? If you have 5 sweets with you, if then you finish 1 sweet, then after that you again take it another second sweet, and after that another second sweet, means that the exposure is longer. So the acidic situation in your mouth is longer. So how about the caries development? It will happen. So the process happen, that is the demineralization, right? Okay. So you need to remember this, how the food happen when it's enter to our mouth. We call it as a Stephen curve. As a dental student, we have dental student here? Tak ada, no. Yeah, only one student. That's my student. Yeah. So as a dental student, you need to remember this curve. This is a very important, basic, basic caries development, and is useful when we want to do a diet counseling for our patient later, right? Alright, then also these protective factors and pathologic factors in the condition of no caries and caries, yeah. The protective factors is high salivary flow rates, yeah, and also the bacteria's metabolism of amino acid and urea, and it can raise in blood pH, and also the supply of calcium, phosphate, and fluoride, which is, as I mentioned just now, the remineralization. Yeah, you need to take note, yeah, because the question will ask, the question is about all this that I'm stressed just now, right? All right, so we understand about the carbo. I know that you already know about the carbohydrate, but is it whether the carbohydrate can cause dental caries or not? Yeah, so actually we know that sugars can divide to monosaccharide, disaccharide, and polysaccharide. Yeah. So what's the chemical structure, or what's the sugars can cause a dental caries? All can cause the dental caries except for the galactose. Yeah. So if we eat all the foods, I think after this is come across to your mind whether the food can affect a dental caries, can cause a dental caries or not, right? Yeah. But never mind, if you apply a very effective toothbrushing methods, you can prevent the dental caries too. Plus together, if you need to take care about your diet intake, right? Okay, so again, this is about starch and sugars, yeah. It can break down the polysaccharide to disaccharide and monosaccharide, right? And yeah, as I mentioned just now, we always talk about sugar. What type of sugar? According to Coma in 1989, said that sugar we can divide to 2 types. First is intrinsic sugar, the second is extrinsic sugar. Yeah, the intrinsic sugar, where we can get it is we can get the intrinsic sugar inside the cell structure of unprocessed food, for example, fruit and vegetables. Yeah. But then the extrinsic sugars is we can get it from the outside of the molecule of the food. For example, table sugar, white sugar, brown sugar, right? That is extrinsic sugar. Yeah. Okay. While we talk about sugar, we need to think about the words of OSE. Yeah, we always know that about the sucrose, maltose, fructose, yeah, lactose, dextrose, glucose. This is all the sugars. Yeah, the sugars. Whether is it the sugars can cause a dental caries or not? Yes, right. You must confident to answer my question. Yeah? Is it this sugar can cause a dental caries or not? Yes, that's good. Yeah? I know that you are not sleepy here. Yeah? Right. So this is the content of sugar in foods. For example, this is only a few pictures that I can take and share with you for this lecture today. Right? You can see that for 1 can of Coke here, is about the 12 teaspoon. Can you imagine if you drink 3 can of Coke a day? Yeah, it's not only can cause obesity as presented by the Prof B Koon just now. Yeah, it's and also can affect your teeth as well. Right? Okay. So you know NMES? Yeah. Have you heard about the NMES before? No, so I'm glad that I can share a lot of knowledge with you today. Yeah, so NMES is a non-malt extrinsic sugars. Yeah, so NMES is included all other extrinsic sugar. Is also carcinogenic as fresh fruit juice, honey, and syrups. Then, do you have any question about NMES? Okay, I'll ask you. Why the fresh fruit juice can cause a dental caries? Fructose, right? Yes, correct. You are very, very intelligent. Can answer my question. Very clever, right? All right. So because the carcinogenicity between the fruit juice and a whole fruits is different. If you eat the whole fruit, for example, apple, it may take a lot of chewing that you need to do, right? So it can stimulate the saliva in your mouth. So that saliva can become a buffering in your mouth. Then it can prevent the acidic situation in your mouth. However, if you drink the fruit juice, the molecule is already process it, so it can cause a dental caries. So that's why we recommend to our patient to take fresh fruits, the whole fruits, not the fruit juice, right? All right, even without added sugar. Yeah, all right. Oh, okay. Okay, so we need to be aware about the hidden sugar. We eat a lot every day, but we do not know about the sugar inside there. We need to aware about that, right? Okay. So this is the hidden sugar that maybe inside. Yeah. For example, in ketchup, in tomato, in sauce, in sauce, soya sauce, tomato sauce, or chili sauce, the sugar content is very high. Yeah. It's really carcinogenic. We need to take care about that consumption, right? Okay, I mentioned early of my presentation shows that it's a very significant between sugar consumption and dental caries. So there are a few classical study that done before that shows that a very significant relationship between sugars and dental caries. So we can see that relationship through observational human study, experimental human study, and also animal human experiments. And then nowadays there are a lot of study done to see whether that's to prove that there are significant relationship between sugars and dental caries. So, according to observational study by Dr. Weston Price research, who is Dr. Weston Price ni? Yeah, Dr. Weston Price is a doctors, medical doctors who like to circle the world. Yeah, he like to circle the world, the globe, to study about the primitive people. So from his journey, if he discovered that people whose diet had not changed for centuries had few dental or other medical problems. Yeah, but when these same people came into contact with the displacing foods of modern commons, if they are starting eat a conventional diet, a modern diet, the rampant tooth decay and progressive facial deformities follow. Right. Okay. So you can see in this picture. Yeah? So the second observation study is Tristan dan Cunha study. Yeah. This also classical study. The Tristan dan Cunha is a remote volcanic island in South Atlantic Ocean between Cape Town and Buenos Aires. Yeah, this remote non-mobile community of some 300 people have limited contact with outside world. At that time, these 300 people in this volcanic island really stay together with them, not contact with other people, and they implement the traditional diet only. They only eat the potato and fish, which is the diet very high with protein at that time. Yeah, at that time, early studies by Simpson, Sockness, and also Sockness in 1954 show that the prevalence of caries in the first permanent molar of 6 until 19 years old was zero. At that particular time. So means that there are no caries anymore when these primitive people implement the traditional diet, right? However, in 1950, there are increased communication with outside world. Yeah, with the outside world because of working, they provide the fish to the outside people for the fish processing. Yeah. Then in 1961, the volcanic eruption that in that island, then all the population there moved to the England. Yeah. Then after that, they come back to that island. Yeah, to that island. Then they were dentally examined in England in 1962, and again they had returned to the island in 1966. Then from that result shows that the increased caries prevalence from 50% in 1962 to 80% in 1966. Yeah, and also we can see that the prevalence is increased very fast. Yeah, after they implement the conventional diets. Yeah. So what happened to us that every day eat the conventional diet? What happened to us? How many canned drink do you drink for a day? How many sweet do you take during the lecture? Right. Right. So you need to think about that. Then also you need to think about your teeth too. Right. The third one, we continue with Hopewood House study. This is a longitudinal study conducted between 1947 until 1961 on children living in Hopewood House, which is an orphanage in the remote of New South Wales. Yeah. The first analysis was conducted on a group of 82 children aged 6 until 13 years old who fed on lacto-vegetarian diet, consisted mainly of whole wheat bread with germs, fresh fruit, vegetables, egg, milks, and fruit juice only, and almost absent of refined carbo. Yeah, so honey was provided on occasion only. So at the Hopewood House, children aged 8 through 14 years old had DMF. DMF means decay missing filling. Yeah, rate between 0.9 and 6.0 only. However, as compared to the same age group with the other school children, normal school children who implement the conventional diet at that time, the DMF is 5.3 and 13.9. Right. However, when these children from Hopewood House, they leave the Hopewood house, then they implement the conventional diet. We can see that, the cavity rate increase that match with the normal children. Okay, we continue with the experimental study. This is very popular study, White Home study in 1946 until 1951. This study is a 5 years investigation among 3 adult patients in a mental institution at White Home Hospital, Sweden. This is unethical study. We cannot repeat this methodology. So the institution diet was nutritious at the beginning, contain little sugar and no between meal snacks. The dental caries rate in the inmate was relatively low at this moment, right? So the experimental design divided the patient to the 7 groups. 7 groups. Sugar was introduced either at mealtime, in bread and solution, or between meals. The conclusion shows that the White Home study shows that the physical form of carbo, thickness, oral clearance, time, frequency of intake were much more important in carcinogenicity. That was the total amount of sugar ingested. Means that if you have 5 sweet with you, if you take at one time only, the sugar exposure is only 1. But if you take 1 and then finish it and continue with another one and continue with another one, it means that you have 5 exposure, right? So it can cause a dental caries and is very dangerous for the acidic situation in your mouth. Alright? Everybody understand now? Stay with me? Okay, thank you. So the second experimental study is the Tuku sugar study. It's about the xylitol. How about the effect of xylitol to the dental caries? So this study done because of during the Second World War, they faced with shortage of sugar production. So they try to get another alternative sugar. So they think that xylitol is good. So they try to take a xylitol lah. So then after that, about 117 subjects was given specially prepared diet sweetened with sucrose, or table sugar, fructose, or xylitol. They compare with 3 type of sugars, either sucrose, fructose, or xylitol. Then the results show that there are increment of caries or DMFS. For sucrose is 7.2, fructose is 3.8. However, there are 0 for the xylitol, right? Okay, time's up already. I need to be faster, right? This is the table, yeah. So as we know that sugars in relating in oral health is referred to fermentable carbo, as I mentioned just now, right? So in theory, if carbohydrate is omitted from diets, caries will not occur, right? However, preventing in intake of carbo in diet is not practical because it is the main source of energy, right? You need the energy, you need the carbo in your diet to supply the energy for you to do the physical activity. So we need to control it. We need to know which diet that we can take and which one is cannot, right? Okay, there are 6 key issues in preventing of dental caries. First is in terms of food form, frequency of sugar consumption and other fermentable carbo, retention and clearance time, and also nutrient composition. The potential of the food stimulates saliva, and also the combination of foods and diet patterns. This is the key issues that are very important in the process of preventing of dental caries. So we go one by one. For example, food form, the difference between sticky and liquid. So the sticky one is more harmful as compared to the liquid one, right? So please choose your food wisely when you want to eat, right? The second one is the significant frequency of fermentable carbo consumption. you need to remember about the Stephen curve as I mentioned just now, right? Okay, make sure that if you want to eat the sweet food, still you think that you get a good result, so you want to celebrate it, then you want to have a cake. So you need to take it wisely, right? And also you need to think about retention and clearance time. The clearance time is the time from the carriogenic exposure until the food is cleared from the oral cavity. However, the retention is the retentive of foods stuck between your teeth, right? Okay, and also nutrient composition. You need to think about the cariostatic food just now, as I mentioned just now. What the type of food, the example of cariostatic food that you need to take, right? And the potential of the food to stimulate the saliva. I also give you the example already just now, whether if you want to drink the fruit juice or the whole fruits. Yeah? You need to think wisely. Yeah? And also the combination of food or diet patterns. Yeah? You need to consider the choice of item of food or drinks, the combination of items taken together, the sequence itself, the time taken to eat, and also time lapse between the consumption. It doesn't mean that if you want to eat chocolate or ice cream or cake, you can take it, but you need to take it in properly in a correct sequence, right? So you can eat the cake, but then you need to plus with the plain water, or you eat the cariostatic food. Then after that you drink the plain water, then about 1 hour after that you brush your teeth, right? Okay, so decay promoting foods and beverages, how to calculate it? I want to share this important information with you so that you may know whether you are exposure to the carcinogenic food or not, whether you are under category low risk, moderate risk, or high risk. Yeah. So this is the foods according to Tufts University. All the liquid food you need to times by 1. Or the solid or sticky food you need to time by 2. Or the slowly dissolving, for example, hard candy, sweet, and etc., you need to time by 3. Then after that, you can get the score. You can calculate by your own. Then you know whether you are under low risk, moderate risk, or high risk, right? And then this is the example that I did. The sugar exposure for this patient, I used the 24-hour diet recall. So I calculate the sugar exposure. So the total sugar exposure for this patient is 10. So this patient is under high risk, right? Okay, so how to do the diet counseling? They have the 6-step dietary sugar advice. First, you need to identify higher risk of patient. Second one, take a dietary sugar intake history, like 24-hour diet recall, just as I mentioned just now. You need to set the goal for that patient, which category of that patient, whether it's high risk, moderate risk, or low risk, right? And then develop action plan. You need to plan the diet plan for that patient. And also you need to monitor after that when the patient follow your program. You need to monitor and review. Is still relapse, the patient still not change anymore, you need to refer to the dietitian to advise it, right? Alright, so in the dietary recommendation for prevention and management of dental caries, you need to advise the patient follow food pyramid. In Malaysia, for me, we have a Malaysian food pyramid. So we need to follow Malaysian food pyramid to ensure that the patient take a balanced diet. Then after that, for the amount of food, we refer to Malaysian healthy plate, which is emphasized on quarter, half concept. Yeah. Okay. The sugar recommendation, I also want to share with you. According to WHO in 2006, the recommended sugar, added sugar per person per day is only 12 teaspoons per person per day. Not more than that. It's only 12 teaspoons per person per day. You need to calculate it every day. Yeah. And then continue by, according to WHO in 2015, the recommendation intake of non-milk and reduced sugar is a maximum of 60 gram per day, which is about 10% of daily energy intake. Yeah. In addition, suggest a further reduction in the intake of free sugar to below 5% of total energy intake. According to American Heart Association, says that men must take only 9 teaspoons of sugar per day. And then for female is about 6 teaspoon sugar per day only, not more than that. If you implement this one, you can prevent the obesity problem too, right? Okay. Yes, this is the summary, right? So, as the conclusion, the food you eat can be either safest and most powerful form of medicine or the slowest form of poison. It can be a poison and also can be a medicine. With that, thank you so much.
Test. Thank you very much, Dr. Ruhaya. Very inspiring lecture. A lot of important information related to our daily food intake. So after this, we will be more mindful in taking food. Okay, should I take this donut or not, or candies? Right? And I should brush my teeth after this, something like that. And the last one is, I noticed that I recognize the suku-suku separa from Upin Ipin. Upi. I think many of you know that, right? I recognize that from Upin Ipin, one of my favorite cartoon.
Yeah, because you want to promote the suku-suku separa play. Because we know that the carries, as presented by the Prof just now, the prevalence of obesity among children is higher in Malaysia, because we face with the double burden disease too, right? And then also the dental caries also higher among children in Malaysia. So how to promote it and how to prevent it? Now we know that the mass media play a very important role to ensure that disease can prevent. So the only way is through the Upin Ipin cartoon, as well as for the mothers, we develop apps. Myself also develop apps to the parents to prevent the dental caries. Yeah, so that to my research, we found that the prevalence is reduced when we supply the parents the apps on how to about the sugar consumption, and then what to do, and then when the parents have well educated, they can implement that method to the children.
Right.
So
Interesting.
we can prevent it.
Interesting. Right. Okay. Thank you, Dr. Ruhaya. And we need to move to our next speaker. She is Ibu Citra Widya Kusuma, MPH. Hi there. How are you, Ibu Citra?
Good, how are you?
Very good here, and thank you very much for joining us. What time is it now there? Very late.
10:35 p.m.
10:35. It's quite late for you, and so thank you very much. We very appreciate your time, and thank you for still awake for all of us. So Ibu Citra, now she is in the US, and she studied, she is now taking her doctoral degree in Tulane University, if I'm not mistaken. Yeah, Bu Citra. So Bu Citra Widya Kusuma, MPH, actually she is one of our faculty member here. She has passion for public health nutrition. Her research primarily focuses on maternal and child nutrition, community nutrition interventions, and public health policies to improve nutrition outcomes. And for this session, Bu Citra will deliver her lecture about nutrition and health system strengthening. Time is yours, Bu Citra.
Okay. Let me share my screen. Is it visible for everyone?
Yes.
Yeah, Thank you. Okay, good morning, everyone. In Indonesian time, I'm so excited to be here. Before I start, I will say sorry first because I'm having cough at the moment, so maybe you will hear me coughing here and there. I'm so sorry, especially for you who is joining online, because I believe it will be so uncomfortable to hear me coughing through your ear. So, yeah, my name is Citra. Today I will share a little bit of my knowledge about nutrition and health system strengthening, and a little bit of about me. As the moderator mentioned, I'm a faculty member in the Universitas Gadjah Mada. I also work sometime in a consultation both with national and also with the district level government, mostly improving the health programs. And currently, I'm one of the Fulbright scholar in Tulane University. Now, moving on to the outline for today, I'm gonna talk about the health system strengthening, and then also talk about a little bit in the Indonesian context, and then about the primary healthcare in community nutrition, and last but not least, about the community empowerment strategies. Now, moving on to the strengthening health system to improve health outcomes. The key word here is the strengthening. So when we see the word strengthening, of course, we're not starting from zero, because strengthening is we improving what is already exists. Now we have to know what we want to improve, what we want to getting better. So we have to know what is exists. What is the existing thing that we want to improve? Health system itself is a huge thing. It's a very big thing that we have to understand. That's why we need a framework. Framework, or some people also call it models, it's like a lens or a glasses for us to see which way for us to improve, or to see what gaps in the community or in the population or in the system itself, how we improve them. There are a lot of frameworks and available, I believe, but one of the common frameworks available that is commonly used is the WHO framework. That is consist of, excuse me, 6 building blocks. It's service delivery, health workforce, health information systems, access to essential medicines, financing, leadership, and governance. I'm not gonna go through one by one, because I already sent one of the reading for you guys to see. It's pretty, I know it's quite thick, but it's pretty easy to read and it's very interesting. But each block that exists in the health system here, it's not enough just to be exist. It has to be work or link to each other and work as a system, because it's a health system, so it has to link each other and work as a system. Does it exist where it doesn't work as a system? Trust me, there is a lot of cases where it's only exists and not working as a system in the field. So what is the service delivery is like the intervention, like the service package that we want to give to the population. Health workforce is like the person who gonna deliver the service. So if we want to deliver vaccine, for example, it can be through the health workers, it can be through the health volunteers, it can be through the community. That can be included as the health workers. The health information systems is the information systems that we can use to inform the populations about the system, the service delivery or the intervention they want to give. Access to essential medicines is about the basic health needs, especially for the population that what is the basic service they need. Financing, it's related to budget, money, in order for them to deliver the service. Leadership or governance is about how to manage everything. So all everything is linked, because delivering the service or the intervention without the health workforce, it can be delivered, because who gonna deliver it without the health workforce? The health workforce or the person who gonna deliver it without money, how they can deliver it? So everything is have to be linked. And the ultimate goal for all this is to improve health outcomes of the populations. So with the good access, with the good coverage, with the good quality care, the good safety, of course, we want to the health outcomes of the population to be improved. Now, in public health, we cannot target all the populations, because, excuse me, if we target all the populations, we cannot deny that we have limited resources. For example, if we talk about budget, nobody will say like we have unlimited budget. We will say, oh, this is money that we have. How we should do with this money, right? Or we have this amount of person that can work with us. That's the number of health workers that we can work with us. So we have a limited resources. So we have to prioritize who we should target first for our populations. The logic will be, if we target the most vulnerable population first, those who have access will still have the access to the service without any extra intervention, if that makes sense. So those people who is most vulnerable most likely don't have access, even though we do all the efforts, we have done all the efforts, have done everything that we can do, but still the outcomes is not as expected. Sorry, is it okay?
Yeah, you're fine, Bu Citra.
Okay. So what was I before?
Vulnerable population. We do all of the effort.
Yeah, so even though we have done all the efforts, it's still there are some population that is still not can have the access from what we can have done. So I will give you like a little bit of hang on. Visual. Can you still see my hang on.
We still see your slide, the WHO Health System Framework.
I think it should be, it's not that one. Is it? Sorry. Sorry for the trouble, everyone. Should I start share again?
Yes, please.
Okay. Just a moment. Okay. Okay, so this is a little bit of the visualization about what I was talking about. So if you focusing on um that everybody receiving the same interventions, then most likely there are some people not still not having access to to whatever it is one that you want to achieve, because some people need more interventions because they don't have access. Some people have more than enough. So it's as expected that maybe the the outcomes that you were expected, it will be never be achieved, because like even though regardless the amount of efforts that you've been um done, it's maybe a lot, but the the outcomes, it's still not there. It's different if you focusing on to more targeted populations when you know better your populations, who are they, where they live, what are their characteristics, so you can prioritize them and you can be tailored more your intervention with this certain populations, so this population who already have access still can have access to the interventions with their existing access. But those people with, before, when they don't have the access before, with your extra efforts in your intervention, now they have the access. So at the end, with the same amount of efforts, uh, at the end, the outcomes will be more. So the programs, it will be more effective and efficient, if that makes sense. So it's very, very important to get to know your populations. Excuse me. Now, um, I was talking about the health system framework for and how to operate this. This is one of the extra framework that I've been using, me with my research group, how to map out, because as I mentioned before, that each of the building blocks cannot just exist. It has to be linked to each other and it works as a system. This is adopted from the Mintzberg management framework, and it's called an organization implementing unit. So it's always starting from the target populations. And when we know our target populations and we know their characteristics, we can always see what sort of interventions they need. The intervention can be everything, it can be anything, and we can always modify it. Depends on the target population situations, whether they live in the urban area, whether they're living in slum area, whether they're living in a rural area, or they're living in a remote rural area. Even though you pick one intervention, it will be so much different, depends on the situation of the target population. Now, when you know who is your target populations, you can modify your intervention based on the target population, and you know who gonna deliver this intervention to the target population. You cannot just it's there's no way one fit for all for in the health systems, because if you say, oh, we have to deploy doctors, maybe in certain circumstances there's no doctors exist in that settings. We have to utilize community, or we have to utilize peers, or religious leaders, or whoever it is that will works or can be our partners into to make sure our service will be delivered to our target populations. Then we need support system. What are the support system in order for the health workers deliver the service? It can be financing, the money, budget. It can be the health information systems, how to what is the record and report systems, how to inform the target population about the service delivery, how to monitor and evaluate the services, and then how to improve the access to essential medicines. It's the work between those three, the support system and the manager. The manager work between those two, the quality control and the support system. The quality control is to make sure that the quality and safety of the service delivery. And then on top of it, and everything is the leadership and the government. I mentioned before that some of the cases that it's not working as a system, because like based on the findings in some of my projects, it happens is only work here when the health workers are very overburdened. They just keep delivering the service without any support, enough support system and enough quality control, or there just exists like the government, the leadership are there, the budget are there, the information system are there, the access are there, but they focus on different things. So for example, the target population have issues on diarrhea, for example, but the budget of this particular places are mostly on HIV, and the government are more focused on HIV and doesn't have enough budget for diarrhea. So the health worker here to improve the problem on diarrhea, they face a lot of challenges because they don't have enough budget. They cannot give quality care to address this diarrhea problem because it's not on the government focus, and the budget is not enough for them to have enough logistic to intervene the target population for the diarrhea issue. That's one of the random example that I can take on top of my mind. There's a lot of things that we can see when we map out in the system. Sorry, in the system, and when we can see. So it will help us to see what in the system, what is already what's in the system, what we can improve in the system, what are the gap that we can improve in the system, if that makes sense. This is one of the project that have been done at East Nusa Tenggara when we mapped out. As you can see here, there's a lot of field workers involved in so many different intervention programs targeting the population here. But as you can see, there are still people that is unreachable. Now, there are a lot of recommendation, or there are many modification or improvements that we can use or we can do to improve this program, to like it's either change the program, or we can use other field workers to reach these populations. But in this certain programs, because it was talk about majority the programs that is mainly um, managed by the central government. So whatever the district, whatever, even though the district government see there are so many challenges, they cannot do much because most of the program here are mandatory from the central government. That's why the part of the recommendation here is more intervention from the district government. But it has to be noted that we need capacity building at the district government, because we have to make sure that the district government also ready to make some improvement into their program. Because sometimes, uh, even though they know what are their challenges, they're not sure what are the solution they can provide to address the challenge they have. Now, moving on to these first delivery points. So in public health, there are some delivery points of in delivering the delivery intervention or the service package. It can be in the community, it can be door-to-door services, it can be in the hospital, it can be the primary healthcare services, it can be through village midwives on the private clinics. One of the crucial point of delivery is at the primary healthcare. It's also mentioned at the Alma Ata Declaration. You can also read in the document that I sent. It's part of your pre-reading. As it's very crucial because it's one of the closest settings or centers that the community can reach, especially like in Indonesia, where Indonesia is a huge country, and sometimes the primary healthcare centers is one of the closest one that community can reach. And I think in the community nutrition, they have three major roles. The first one is providing the logistics, including like vaccinations, supplementation, and also individual need, including like counseling and like breastfeeding supports, and also monitoring and evaluation that includes early detections. It include the under and over nutritions, and also collecting data of the community nutrition status, and also capacity building. Capacity building meaning like, because in Indonesia especially, we utilize a lot the community volunteering health workers. So as part of the follow-up of the monitoring and evaluation activity, is including into the activity is the capacity building. And the last but not least is the public health advocacy. This is, I think, the most important one, as in the past few years, the government giving out enough money to the village that they can use to improve the development of the village, which mostly they use it for infrastructure, even though from the central government, uh, already mandate to them to um, secure some money for health. Trust me, even though they say the health, it's still about the infrastructure. So it's very important to build community partnership and collaboration, doing health promotion. And the most important one is engage with the community leaders to make them aware about the health issues, the health problems around them. So it's not separating that this is your problems and this is my problems, but this is our problems to solve. So, in that way, the health issues in the community can be solved faster and more efficient. And a little bit in Indonesian context, maybe some of the speaker also mentioned about Posyandu here. So Indonesia is the largest archipelago in the world to form a single state. It has like 38 provinces, 416 districts, and more than 30,000 villages. So you can imagine that it's very challenging to provide standard care package for people, especially for those in the rural remote areas. That's why like in 1983, the government initiated a program called Posyandu. At the beginning, it's initiated to just to improve the child survival and the development. But then it became the backbone of the country healthcare delivery system because it's available in every villages. Nowadays, it's supported by 4 different ministries and institutions. So Ministry of Health, Ministry of Education, Family Planning, and Village Development. And the most important one that is nowadays is community-led program. So it's coordinated by the village leader and by health cadres. So health cadres is like a community um, volunteer. They are trained to giving basic health care. I'm not gonna talk about the care that in Posyandu are giving, but I'm more gonna talk about how this Posyandu evolving from uh just giving out the basic needs of the how it was initiated just to fulfill the basic needs of access to her health service, and then it evolves to the capabilities of the person to encourage them to actively maintain their health. Now, moving on to if we're looking at the post development theories, it's more like in the community participation. So nowadays, it's more encouraging the community to participate more to gain the awareness of the community to demand what they need. So from there, um, if they know what they need, it will. So based on the post-development theories, it's believed that the local knows better about the challenge, what they need, what their problems are. So it will be tailored made. So the development, the improvement are based on what the need of the people or the community itself. So it's very interesting how to see one program can be evolving into one thing that is um getting bigger and suitable into one particular community, because like if we can see now, the community participation is very, very important. Looking at how, because because when we putting the community as the subject, not just the object of the program, they can demand and they know better about their issues. So they don't feel like they just a patient, they just receiving the program, but they know better that I need this for myself. So I think it moving on to the community empowerment strategies, in my opinion, it's understanding better the target population. So it will give you like give you a better picture of population itself. If you know your target population, what are their characteristics, their demographic, how what is the specific health issues in that certain target populations, what are their problems, what the determinants of health around them. You can choose the resources that exist around them, so you can utilize what is resources available around them, so it will save you a lot of money and cost and energy. And then you can also prioritizing the intervention strategies. So knowing your population, it will change um a lot of things in your program management. And then you can choose the evidence-based interventions based on your community. I know that what sort of evidence that you can choose, because there are a lot of evidence-based interventions available nowadays. And looking at your population, what sort of context that you're working with is uh, very crucial, because it will make it into context where when you decide which sort of interventions that you want to choose, and which strategy that you want to apply in terms of to implement your interventions. So I think the basic of all is knowing your population better is the basic of the community empowerment. When you know your population, you can talk to them um to through various methodology, with stakeholders that you can work with. So from then on, the chance of um the success of your programs, it will be higher, rather than you can just randomly choose interventions that you don't know whether it's gonna work out or not. So yeah, I think that's all from me. I hope it will give you a little bit of things. If you want to reach out further for me, sure, you can send me an email through this email.
Thank you
Thank
very
you.
much, Bu Citra, for your very insightful lecture. One thing that I highlight from your lecture is always start from your target population. Yeah, understand them better, understand their characteristics, culture. It will higher your success rate for your program. All right, thank you very much. So. Now we have our real discussion session. Yang tadi nggak real ya. Real discussion session. Do you have any question? Yes, we have here. I know you, Hani, right? Yes. And our fellows who join online, please also have, if you have questions, you can raise your hand or maybe just put your question in the chat box. Yes, please, Hani. You want your twin join you too? No? All right.
It's come for me. Hello, my name is Nureen Hanisa. You can call me Hani. So my question is for Dr. Ruhaya. Yes. All right. Okay. So my question is, firstly, I would like to thank you for very insightful sharing, because this is very detailed, quite detailed. I guess it's very beneficial for us as the dietetic students. So my first question is, just now you shared about xylitol, natural sweetener, right? So my question would be, we often give our diabetic patient an option for stevia or natural sweetener. So the effect of stevia, is it the same with xylitol? That was my first question. So my second question is, previously I heard about dentists recommend us to brush our teeth 30 minutes after we eat. So is it related with the Stephen graph that doctor mentioned previously? So yeah, that's all my question. Thank you.
Okay, thank you, Hanim, for the brilliant question too. Yeah, according to the stevia and xylitol, right? The stevia is good for the diabetic patient. It can control the blood sugar level. Yeah, the effect, the properties of the stevia and xylitol is the effect is same with the xylitol, so it's also can prevent the dental caries. Your second question, apa tadi? What is it? About the brushing, yeah. Yeah, brushing teeth 30 minutes after eating, right? So actually in caries prevention, we must work together to control your diet and also the effective method of toothbrushing. Toothbrushing is not only the brushing techniques that you did, but you need to know how to brush your teeth in effective way, what method you use. Actually, if you eat the isotonic drink, if you drink the isotonic drink, you know, it's not recommended to you to immediately brush your teeth after 30 minutes. You need to wait for a while to neutralize in your mouth. Then after that, you can brush your teeth. Yeah, and I will recommend that if you eat sweet food, you wait for a while. You cannot immediately no need to immediately brush. You can drink a plain water first. Then after that, 1 hour after that, then you can brush your teeth. Okay, thank you. And okay, can I answer your question, honey? You are from UPM. Okay.
All right, thank you. Is there any other question? Yes, please.
Thank you for the opportunity. My name is Tirta Pramana. I'm from International Health Study UGM.
How should I call you?
Thor.
Thor,
But
like
I don't bring my hammer.
Thor,
Yes.
right?
And I'm not son of Odin.
All right.
Okay. So previously,
Nice to hear.
I work as a stunting task force, and I usually meet in the district setting for some meeting in Posyandu, kind of that. But the placement of Posyandu in this for agency in the field is a problem. Most of the Posyandu programs are related to health, and especially related to community-based nutrition recording and reporting at EPP-GBM. Yes. But when there are obstacles, especially funding that providing the complementary food, the district health office sometimes avoid it by throwing it at the community and village empowerment service. Even though the Posyandu for in a sub-district, or we said it kelurahan, they don't have distribution for village fundings. Yes, dana desa. So, what is your opinion on this problem? So, this is for Miss Citra. Thank you.
All right, thank you. One of our superhero here, Thor, but he doesn't have his hammer right now. Bu Citra, do you hear his question clearly a while ago? Bu Citra, are you still there?
Yeah.
yeah. So what is your opinion about the situation that just Thor just mentioned?
Yeah, that was the one of the example that I was mentioned about the when the system is not working, because each of the so I was mentioned before that each of the blocks are exist but it's not linked to each other. So the funding is there actually, the surface is there but they're not linked to each other. So so the problem is now how to solve that, right? The actually in some of the mechanism in the dana desa, there's a musrenbang. We can actually do an advocacy in the district and sub-district level. If it doesn't work, then there's a other force. Actually, if we can see some of the best practices in some of the district, like in, hang on, let me have a train of thoughts. In East Nusa Tenggara, the supplementation is all provided by the Dana Desa. So Dana Desa is there, but sometimes the village leader doesn't want to allocate some part of the money for this because it's not their priority problems, if that makes sense. So my opinion about this is part of the advocacy level. So how we advocate, it becomes the priority of the village leader, but we cannot always say that it has to be come from the village. It has to be from everywhere. Like other village sayings like, okay, in 1 year, maybe the village can contribute for 3 months. They can only contribute for 3 months. The other 3 months, it can come from the puskesmas, and the other 3 months can come from the district. So it's doable. Sometimes they don't want because like, oh, I don't have the money, so it's your problem. It's not mine. And at the end of the day, it's nobody's problems. So
Right.
yeah.
Right. Thank you,
That makes
Bu Citra. So also, Thor mentioned about the program. Now we have many program only focused on reporting and recording and reporting. Maybe we need to do more integrative innovation that just Bu Citra mentioned about. That's why it's the importance thing of strengthening what is already existing. So yeah, that's one of, not one, we have some issues that we need to work on together. Yeah. All right, thank you, Bu Citra. And good news for especially Darwis. Hello, Darwis. Prof. Po is already here, join with us again. Hello, Prof. Po. We have a very brilliant questions for you. So I invite Darwis to again. Sorry, because I'm afraid that I cannot say your question completely. So yes, please deliver your question to Prof. Po.
Hello, Assalamualaikum, and a very good afternoon. So I'm Darwish from UPM Malaysia. So thank you, Dr. Po, for a very insightful presentation just now. And for my question, if a person have unmodifiable factor for being obesity, like gene mutation or syndromic obesity, for instance, and if the particular person have already done to eat healthily according to their needs and also do enough physical activity, but still in obesity state, do these kind of people still prone to obesity related diseases like those NCDs? And if yes, what will be the best intervention for them? And for my second question, for our Malaysia School Supplementary Feeding, or also known as RMT, from my experience, because my mom and my dad both are teachers, and I often go to the schools, and I often seen that most of the food served for the RMT tend to be energy dense rather than nutrient dense, as this actually targeted for poor people to increase their protein malnutrition status, and especially in rural area. So what is your opinion on this issue? Yeah, that's all.
Okay, thanks. So for your first question, I think if they have genetics, so if the obesity is a monogenic or polygenic obesity, you cannot change them. And if they really eat healthy and also exercise, it is likely that they will still be either overweight, if not extremely obese. But the monogenic obesity, usually they are very obese, even from young. So this kind of people, I think they will need treatment taken care of by maybe pediatric endocrinologists or pediatricians who have expertise in this kind of issues amongst children with overweight or obesity. We cannot treat them like if we are a nutritionist and we want to teach them how to eat healthy, but they are already eating healthy. So they need tertiary treatment rather than primary care. Okay. About the RMT, I agree with you. So they actually have menus because the rancangan makanan tambahan is provided by school canteens. For most schools, it's the school canteens who cook for them. And the school canteens actually they will try to follow the menu, but the menu might say nasi goreng, and the nasi goreng is supposed to have vegetables in it, for example. But they find that most children don't eat the vegetables. So when they cook the nasi goreng, it will not have vegetables. So there was once when I went to visit a school just to take picture of the RMT children eating. And because they know I'm there, they give them extra food, like so-called fruits, but the fruits is pisang goreng. So it's also energy dense, even though it's a fruit. But I am quite sure that the pisang goreng is there because I'm there, not because they would get it. Yeah. So I think in terms of implementation, sometimes, although we have guidelines, but it depends on the school canteen operator whether they actually follow the guidelines properly or not.
All right. Do you have any following up question, Dervis? Well, I do have. Prof, so do you think that's a matter of preferences, their preferences, or maybe access to food, like the healthy, nutritious, more nutritious food, or maybe I don't think their ability to purchase the food, yeah, because the RMP is intend to address that problem, I think, right? So I don't know. My assumption is it's culture is there. The people there loves to eat nasi goreng, pisang goreng. It's quite similar here, even though they know the whole food is better, but they prefer pisang goreng, of course, because it's more tasty. What do you think, Prof. Po?
Yeah, I think because I'm a trained nutritionist, so I think that all of us have our own food preferences. And sometimes, let's say for me, I'm a person who really likes chocolate. And I do eat chocolate, but I'm not the kind who will eat chocolate like one whole bar, big bar, you know. I may just take one little piece a day just to satisfy that, okay, I've had my chocolate already. and that's enough. But seriously though, a lot of people may lack the knowledge about healthy nutrition, or even if they have the knowledge, can they afford to eat it, the healthier foods? Like in Malaysia now, especially after COVID, and then there are a lot of like wars happening around the world that makes many of our foods become very expensive because we import a lot of food. A lot of our food items are imported from places like India, China, even the wheat are all like from um, Europe and so on. And because of transportation costs and everything, all the price of food is going up. So because of that, although we recommend healthy eating, are people able to afford to purchase this? Which is why one of our studies now, and in Indonesia, we also have a partner who does the same study. In fact, today they are doing their Indonesian dissemination of the study, which we call SIOFE, Southeast Asia Obesogenic Food Environment. And this is where we try to talk to the urban food retailers, trying to change the policies or ask them to try to sell healthier foods in their retail outlets. In Indonesia, our SIOFE team did the study in Jakarta, and their main focus in wet market. Whereas in Malaysia, we did it in hypermarkets, supermarkets, convenience stores, and also kedai runcit. And later on, we have a small group of students who go to traditional markets as well to study the environment of foods and to see whether the foods being sold are they more healthy or less healthy, and are they affordable or not. This is very important. We cannot always just think of doing health education in school. That is not enough. Yeah.
All right. Thank you very much, Prof. Po. So we still have time, I think. Is there any other questions? Yes, please.
Assalamualaikum warahmatullahi wabarakatuh. My name is Rahana Zelda. You can call me Hana. I'm also from Universiti Putra Malaysia. And I would like to direct my question to Dr. Ruhaya. I had a thought about carbohydrates and glycemic index, and I was wondering if the rate of glycemic index in carbohydrates would affect the cryogenic effects to the teeth as well. Thank you.
Okay, thank you, Hannah, for the question. Yes, it will, the carbohydrate is high glycemic index foods, right? So we know that in carbohydrate itself, just now as I mentioned, when you eat, it can, bacteria in your mouth can use it, right, to produce an acid. So the same function as you mentioned just now is also can cause a dental caries, because all the carbohydrate component, if you eat it, the bacteria will use it and to produce the acid. Then it can cause the demineralization. So if you in terms of food episode eaten, if you after that if you take karyostatic food, so it can stop that process. So then together, if you drink a plain water as well, so it can better the process will stop there, so the caries will not happen. Okay. Yes.
Thank you, Doctor. Follow-up question. So in that case, it doesn't matter if the glycemic index of the carbohydrates is high or low, but the risk of the caries is still there. Is that correct?
Yes, it's true. That's why in the dietary recommendation, you need to stress that 6 steps, issues in dietary recommendation to the mothers that you mentioned just now, right? So the higher consumption of carbo not only affect the caries, but also the other disease in general health.
All right, is that okay, Hannah? Okay, I saw a hand raised there at the back. Yes, please.
Yes, my name is Wei Yan. You can call me Yan. I'm currently study in the Prince of Songkla University, Master of Science in Functional Food and Nutrition. So I would like to ask about Dr. Ruhaya. Yes. So my question is about the functional food. So now I'm studying the functional food and nutrition. So my question about the role of functional foods and dental caries preventions. So how do dairy products and green tea, probiotics, fiber-rich fruits and vegetables contribute to oral health maintenance and the reductions of dental caries incidence? Yes.
Okay, thank you so much.
Yes.
Yan, yeah.
Yeah.
Yan, okay. That's a good question. About the green teas and the functional food. Some functional food can beneficial for dental caries, can prevent the dental caries, as well as for the tea. Some tea, you know, in prevention of dental caries, you know, fluoride. Fluoride is one of the nutrients, you know, that can prevent the dental caries. Then that fluoride we can get it from the tea. The tea tanning. So we also advise the patient to prevent the dental caries with a drink tea. And also the functional food, as you mentioned just now, is also give a positive impact to prevent the dental caries. Okay?
Yes.
Okay, thank you.
Okay, thank you for your answer. Yes.
All right, very clear. Thank you very much. Is there any other question from the online audience? No, not yet. All right. After you, please. Yes. Yep.
Okay, thank you very much. So let me introduce myself. My name is Zedi Kramel Fathi. I'm from Universitas Gadjah Mada, Faculty of
How
Science.
should I call you?
Zedi.
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 Okay.
Okay, so actually I wanna ask this question towards all of the panelists, but probably specifically for Professor Fo. Recently, our elected government is implementing or wanting to implement the free meals towards children in school. And what do you guys think for the free meals program that must be ran with tight budgets? For example, like only around $1 per meal. Would it be important considering the lesser impact it would bring, or should we focusing our efforts into another approach maybe that would be much more suitable to address this kind of challenges? Thank you.
All right. Thank you, Zedi. And you asked all of our speakers to give their opinions about this, right?
Yes.
But specifically Prof. Po.
Yeah.
Right. Prof. Po, are you still there? Nope. Yeah? Yes?
I'm still here.
All right.
I think I don't want to judge the situation in Indonesia because I'm not familiar with the situation there. But in terms of school meals, I know that not just Malaysia does it. In Malaysia, unfortunately, our school meal is only for people below a certain level of income. So it's only for the poor people. And maybe 5 to 6 years ago, we had, as you know, maybe Malaysia changed government many times, but at one point in time, just before COVID, we had a government change where the Minister of Education actually wanted to implement a school breakfast program for all children. Doesn't matter whether they are rich or poor. And to me, I think this is a very good initiative because it will ensure that all the children who goes to school get at least one good meal a day. So, and especially breakfast, because even children from rich families, sometimes they skip breakfast because they are just too tired early in the morning, they have no appetite to eat and so on. So at least they get a good meal in school before they start their lessons. And for the children who are from lower income families, definitely it will help. So there are many studies where what do you call these organizations, the non-profit organizations, global non-profit organizations, who have done school meal programs in countries like in Africa, where a lot of children are malnourished and from poor families, and they find that giving school meals at school attracts children to come to school every day, so school attendance rate improve, and also it helps to ensure that the children gets a good meal, at least one good meal a day, because when they go home they may not get to eat anything at all. So I think this school meal program is important, but I don't want to judge that for Indonesia, because Indonesia might have other issues that I don't know about. So I leave it to the other people to answer.
All right, thank you very much, Prof. Bu Citra, you might have opinion on this issue.
I will say that I will agree with Prof about that it will increase the attendance rate of the school children. I think it also happened in some countries, because like looking at this issue, there's a lot of cases in some countries that already implement this program. You can do like comparison, looking at the situation in each implementation of these programs. And also, as I mentioned before, when we see one program, we should know the setting of each population can be different. But looking at the development theories, we can also see there's a chance of the dependency happen in here. If you're looking at the dependency theory, that the food aid may cause like a superior product, discouragement of the local production, or the environmentally questionable. But the dependency, it's usually happen when
Do we lost her?
but for this program implement from this the Indonesia government itself, so it might be different situation. So when we critiquing one program, it has to be like, in the whole thing. We can use like a lot of theory based on the critical, we'll see it through a lot of lenses.
All right, I think we got your message, Bu Citra. Thank you so much. Dr. Ruhaya, do you have comment on this?
About the milk consumption, actually, in terms of side of oral dental caries, milk consumption is very important for the children, because the calcium content and the phosphorus and everything inside the nutrient in milk can either can improve the tooth structure or not. So for me, the supplementation of milk to the school children, especially what was called a preschool. I think we need to start at early stage, at a preschool children lagi, because that stage is the from the deciduous teeth to the permanent teeth. So the children need milk there, the minerals for the teeth development. So in terms of intervention, I think Prof already mentioned just now, right? Okay, thank you.
All right. So according to the program, the program could be beneficial, but we need to, like Bu Citra just mentioned, we need to see to see it integratively, make sure that the equity is there. And Prof. Paul also mentioned about the success of this such kind of program in other side of the world. And Bu Mutiara, I think she have mentioned she has explained her opinion a while ago. All right, and it still need better design. Yeah, I think our government still work on that. So hopefully it will work good. All right, Chatur. I think this is our last question, if you don't mind, because our time is almost up. Yes, Chatur,
Okay.
please.
Okay, thank you for this opportunity. My name is Chatur Septer Rivaldi from Agricultural Technology UGM. Firstly, to Dr. Ruhaya, I asked about dental treatment for braces teeth. Are people who have braces have a greater potential for dental caries, and how to prevent it? Then for Dr. Citra.
Sorry, Chatur. What do you say? Braces teeth.
Braces teeth. Braces teeth. Yeah.
Yeah.
Yes.
Yeah. What is
Okay.
the best treatment for those who have that? Yeah. All right. Your second question.
Okay. Then for Dr. Citra, I want to ask about health agencies or health system. Maybe this is not related to really health, but more towards in beauty. So my sister-in-law is starting make a beautiful clinic, and earlier Dr. Citra mentioned it that the health system must target the problem in a certain population. Nah, my question is how to identify beauty problem and determine a strategy to developing beauty clinics. Sorry. Okay, that's my question.
I hope you get the question, Bu Citra. All right. We'll hear your answer after Dr. Ruhaya answer his question. Please, Dr. Ruhaya.
Okay, thank you, Chatur. Chatur. Okay. Regarding the wearing braces and caries development, right? Okay. You wear the people wear the braces because want to correct the teeth structure, right? The crowded teeth. However,
We need to pause a while, Prof. Po and Bu Citra, because here is a prayer call right now. It's happening.
Okay, Chato. That's why for those who are wear the denture, they need to ensure that they need to clear the debris, the food between teeth will stuck immediately, because if you do not remove it immediately, the caries still will happen. So the to take care of the braces wearer is more important, and you know, need to be very hardworking to remove it immediately. You cannot just leave it like that, just brush your teeth like that. You need to, I think, for the braces wearer, you need to they have a specific technique to remove the debris between teeth, right? So you need to do it immediately lah. If not, the caries will still happen if the food stuff between there, between teeth. Okay? Okay, thank you. Yeah, for the braces wearer is more important to clean it immediately.
All right, thank you, Dr. Ruhaya. And now come to Bu Citra for the second questions of Chatur about beauty clinic. How do you, yeah.
I think the question is how to, sorry, my internet is quite unstable. Is my voice?
You're good now. Yeah, you're good now.
Okay. The question was how to implement health system in to building health beauty clinics. Is it?
Right, and then how to find issues, problem in the beauty, right?
Okay, I think mostly. I'm not sure. It's an interesting question because mostly my work is in community settings, not in a private clinics. But I think in applying to the private clinics is mostly looking at the target markets. Maybe, I'm not sure. So
Yeah.
if my voice still clear?
Now you're okay. Yeah, you can continue.
Okay,
Yeah, we lost
sorry.
you. Yeah, you lost you for like seconds.
Okay. Yeah, I was saying like if so get to know better. I think get to know better the target market. I'm not sure because most of my work is in the community, not in the private clinics, and get to know the target markets and what is majority of their health problems of this particular target markets will help you like what is the logistics like better help you to build like how to manage or navigate the beauty clinics that you want to build. Maybe I'm not really sure on how if if I'm applying to the community settings, usually I'm talking to the beneficiaries. So if I want to apply, if I want to implement one particular program, I usually come to the community, talk to the people, what what sort of health challenge that they face, if what health access they cannot, what sort of health they cannot access, and I talk to the stakeholders, the community leaders, and I mapped out what sort of things that I can improve from there. So I think you can also apply that in the private clinics, but you can tweak it into different way. Maybe I don't know.
Agree. I think
hope it
so,
answered
Bu
your question.
Citra. Thank you so much. All right, dear audience, our time is up. Thank you very much for all of the speakers, Prof. Paul It's been a very insightful presentation. Bu Mutiara, I don't know if she's there still. Dr. Ruhaya and Bu Citra, thank you very much. And it's been a very fruitful discussion. I do hope that all of the audience get many knowledge, increasing knowledge and insight, maybe also ideas to work on the issues that have been given to you. Thank you very much. And I close this session. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. And I hand this session over to Yopi.
So everyone give big applause for our moderators, Bu Ariani, and so our speakers, Prof. Koon, and also Bu Ruhaya, Bu Mutiara, and also Bu Citra. Thank you so much for joining with us. And make sure pay attention for the lecture materials because that will be your part of your quizzes in the end of the course. And I will try to update all the presentation materials in your log. And after this, you have time until 1 p.m. Once again, you have time until 1 p.m. to enjoy the lunch break outside this room and also just doing the prayer. So see you on the next session, everyone.